So to start the session, can I call upon Dr. Guruprasad? He will be talking on strategies in trauma surgery.
To listen to this masterclass. Strategies in trauma surgeries begins with a comprehensive evaluation which includes ruling out serious polytrauma, which can be life-threatening. For example, there can be head injury, thoracic injury, and so on. And of course, sight-threatening pathology can be there, which could be either closed globe because of lens subluxation or dislocation, traumatic glaucoma due to hyphema or angle recession, vitreous hemorrhage, and retinal detachment due to tears and dialysis, and optic nerve avulsion, especially in children. And of course, the wide spectrum of presentation of open globe injuries, which I'm going to speak on today and emphasize on them. So let us see some case examples. Here is a case example of a subconjunctival hemorrhage that we see day in and day out in our routine practice with sometimes subconjunctival hematoma. We have to have a high index of suspicion for globe perforation because this conjunctival tear is a scleral tear unless proved otherwise, especially in a hypotonous eye like this with hyphema and deep anterior chamber. So maintain a low threshold for exploration, and lo and behold, there is this scleral tear. Some surprises during exploration we do see. This is a blunt injury with a mound of, that is the mound of some tissue underlying the conjunctiva there, and see that this turns out to be a dislocated cataract. Similarly, we can have a dislocated IOL. You can already see the haptic of the IOL creeping out from the conjunctiva here. Blunt trauma case with rupture of the globe, and on exploration we find that there is a scleral tear here, no doubt, but the lens also is totally expelled out of the eyeball. This patient is lucky. He has 6/12 vision, mild hyphema, clear vitreous, a small little hyphema here, and lo and behold, there is this large foreign body under the conjunctiva, but without causing perforation. So we can have lucky patients like this with such a huge foreign body not causing any damage to the internal structures. Thorn prick is very common in our rural setting, and we have this thorn prick causing corneal tear, infection, and traumatic cataract. There is an endophthalmitis, and the primary care physician has to probably suture this, remove the cataract and the hypopyon, and refer for expert consultation to the VR surgeon. A stick injury causing adnexal laceration there, and you should rule out, especially in the presence of a subconjunctival hemorrhage, scleral tear as well, and that has to be exposed and sutured. So exploration is a very important component of trauma management. Hole in the iris is unmistakable. The diagnosis is pathognomonic of intraocular foreign body, and there it is, the intraocular foreign body being removed later on after an excellent cataract surgery by the vitreoretinal surgeon to remove the foreign body. Some tips about how to suture, especially in cases like this where there's a radial tear right at 12 o'clock, bisecting the superior rectus. A retraction suture comes in handy. The entire extent of the radial tear has to be exposed in such a situation and sutured separately. The scleral tear has to be sutured separately and try to preserve the muscle as much as possible. Cut lacerated wounds associated with corneosteral tears. We have to first suture the lid, and after suturing the lid, go on with the speculum and suture the corneal tear, starting at the limbus and continuing with the corneal repair, finally suturing the sclera. So that is the sequence of the suturing techniques in such a patient. Fresh from the badminton court, this patient came within an hour of injury with a shuttlecock. These patients who were taken up just 3 hours after the injury have a lot of bleeding, and this can be avoided by hypotensive general anesthesia, which we have to inform to the anesthetist. And we have to ensure that there is a watertight closure without incarceration of the muscle, which could happen in most of these patients. When there is a iris prolapse like this, especially if the patient is presenting late, we have to take special precautions to take individual suture bites through each lip of the scleral tear and reposit the uvea while tying the suture. By that, we are able to get rid of, prevent or avoid incarceration of the uvea within the scleral lips. My resident called me to see this patient while he was suturing. the anterior part of the scleral tear he had sutured, but then he said there's a bridge of tissue, normal tissue, and behind that there is another scleral tear. And when I went in, I told him to go beyond that and see what is there, and see that you can see that there is a foreign body, which actually has gone and sat there, but in the process it has sliced through the sclera, entered the vitreous cavity, and exited out from the posterior part of the sclera. So, and that part also had to be sutured. When it comes to the secondary part of the management, the timing is very crucial. Definitive surgery timing is extremely crucial. There's a high risk of early retinal detachment in these patients. There's a high risk of phthisis, especially in children, and generally cases operated beyond 2 weeks after primary repair do not do that very well. Some examples of how they can be problematic. In the vitrectomy part, there's usually a dense hemorrhage, ochre-colored. Layer by layer, we have to go posteriorly, try to expose and try to identify the retina. And then we see that the vitreous is strongly adherent to the posterior part of the retina and the disc. So it's very difficult to induce a PVD in these patients. And we have to use all our wits to induce a PVD, trying to pull in different directions, trying to use different vacuum settings for these patients especially. And finally, it is possible, fortunately, it's possible to induce a PVD and go on with the vitrectomy. So just to show that it can be a problem inducing a PVD in these young eyes, which are prone for trauma. Another patient who had been operated just about 2 weeks ago for a scleral tear, and you can see that the secondary definitive surgery is in progress. The vitreous hemorrhage is cleared, and you can see that there's a large scar of sclera here, a large scar in the sclera, surrounded by subretinal hemorrhage, and there's a macular hole through which the subretinal hemorrhage is continuously coming out. So we did a fluid air exchange to remove as much as possible of the subretinal hemorrhage, and by another simple innovation, by repeated fluid air exchange, we could express most of the subretinal blood out of the macular hole. And then, of course, we could laser and tie the band, laser around the scleral injury. This is another case of definitive surgery 2 weeks after the primary surgery. You can see the ochre-colored blood, which is so common in these patients. So again, PVD is difficult. Fortunately, it was there in this patient nasally, but when we came to the temporal side, we could see that there was incarceration of the retina on the temporal side, and we had to resort to retinectomy and release this adhesion between the retina and the scleral scar, and then proceed with management just like a GRT. A blunt trauma causing globe rupture with so much hemorrhage so much suprachoroidal hemorrhage that there was expulsion of the contents of the eyeball, blood, vitreous, and even the retina, as you can see here. This is retinal tissue. And there's no way of putting it back, and we had to excise everything that had prolapsed. Following which we sutured the lips of the scleral wound. And then we did a suprachoroidal tap after a week using the trocar cannula, guided by the ultrasound, of course. And you can see that a lot of suprachoroidal hemorrhage was possible to be removed by this technique. And a week later, we took up the definitive surgery for the vitreoretinal problem. And initially, we cleared the hemorrhage and membranes in the pupillary area by translimbal route. And then you can see the retina is totally detached. The peripheral retina had got strongly adherent to the iris root, which had to be excised by indentation and a careful retinectomy in the periphery, preserving as much retina as possible. So this is the 360-degree retinectomy that was necessary for this patient. And then, of course, a lot of subretinal and the suprachoroidal blood, which breaks through into the subretinal space, came out in this patient. And then finally, it was possible to reattach this retina under PFCL, although there was this band, this retinal fold, which was not possible to reattach. This is probably due to the residual choroidal blood that was there, causing a mound, and redundancy of the retina also added to causation of the fold, but it dissolved over a period of time. Last case, choroidal scar due to an injury. You can see that there was a corneal tear if you saw the beginning of the video. And this is the large choroidal scar starting at the disc and extending up to the periphery. This had to be cauterized all around to sort of isolate the scar from the rest of the retina, which was being dragged. And then we had to actually cut this retina from the scar with scissors rather than using the cutter to save the retina being chopped off. So in an attempt to save as much retina as possible, it was necessary that we had to cut this retina. And then we did a fluid exchange, and you can see that the retina is isolated. And of course, laser had to be done in the this patient did recover some vision, at least the field of vision was improved. Lastly, a word about sympathetic ophthalmitis. This is a patient who had nothing inside the eye, but when we discussed this with the patient, he said that he wanted the eyeball at least to be saved, and so we sutured it. So sympathetic ophthalmia can be a consideration. It is rare though. We have to discuss it with the patient and manage. We have steroids, we have immunosuppressive drugs, and therefore I think we can preserve these eyes. So take-home points: know when to suspect occult rupture, rule out intraocular foreign body in penetrating trauma, be wary of endophthalmitis. Primary repair is an emergency because of the reason that there should not be an endophthalmitis. Definitive vision restoring surgery is best done within 2 weeks of the primary repair, and discuss about sympathetic ophthalmia with the patient in badly damaged eyes. Thank you very much.
Thank you, Dr. Guruprasad. We'll have a discussion in the end of the session. Can I now call upon Dr. HanyHamza for an interesting talk on management of primary and iatrogenic macular folds.
Thank you very much. First of all, I would like to thank the Vitreoretinal Society of India for the kind invitation. Dr. Vishali, Dr. Shroff, Dr. Babu, Dr. Mangat, and everyone. My talk today would be about the management of primary and iatrogenic macular folds. Iatrogenic post-vitrectomy macular folds can occur post-vitrectomy as well as post-conventional retinal detachment. The risk factors for post-vitrectomy folds include superior bullous retinal detachment, the use of gas tamponade, incomplete drainage of subretinal fluid with a large amount of fluid in the macula at the end of surgery, and it can also occur in cases with posterior slippage after giant retinal breaks. Usually, post-vitrectomy macular folds can have a drastic effect on vision, and Hayashi et al. Have reported progressive loss of photoreceptors and thinning of the outer nuclear layer, as well as apoptosis in these layers within the folds of the retina that occur post-operatively that lead to permanent defect of vision. So this is the first case I'm presenting. This is a post-vitrectomy fold. It's a male patient, 55 years old, with a left upper bullous retinal detachment. I did him vitrectomy and gas, and all through the post-operative period, I could see the retina attached, and I was happy. When the gas was absorbed, I checked the vision of the patient, and he said that I'm not seeing well. His vision was only 360. When I looked more closely, there was a post-vitrectomy macular fold, as you can see in the posterior fold. So I went in again, and I checked what's going on. I found that this fold is extending from above the disc to the posterior pole and below the macula. You can see a bigger fold below the macula, but the horizontal striae extend across the macula. I used the 39 gauge needle to inject subretinal fluid in the posterior pole and detach the retina posteriorly again. I inject slowly in order not to create a macular hole because of the rapid rise of pressure in the subretinal space, and this can occur in these cases if you inject rapidly. Usually I put the fluid in a silicone pump and inject slowly, step by step. Now I have the posterior pole detached again. I put perfluorocarbon on the posterior pole to press on this fluid and iron the retina back from posterior to anterior and flatten the fold. As you see, the fluid has been displaced anteriorly, so I go again with the 41 gauge cannula and start absorbing or removing the fluid in the subretinal space, which leads to reattachment of the retina from posterior to anterior. Do not expect the memory which remains in the retina as these white lines to disappear instantaneously, but it will resolve post-operatively. Despite everything I did to this patient, his vision improved from 360 to 636, but not more than that. Obviously, the damage can be quite permanent in these cases, and therefore prevention, as we are going to discuss, is much more important than to treat the patient after the fault happens. Now, the second case, this is a case I did actually 5 years ago. It's a primary macular fault. It's a 2-year-old child with a squinting left eye and referred to me by his pediatric ophthalmologist for an unusual fundus appearance. And this was the fundus appearance, a macular fold extending from the optic disc to the temporal retina, and clear vitreous membranes, something like a vitreous veil. Ultrasonography revealed a short axial length of 18 millimeters with a completely normal anterior segment. This is the ultrasound showing the short axial length, and the diagnosis was a posterior microphthalmus in which there is a short axial length with a normal anterior segment size, short posterior segment with thick scleral fibers which can lead to exudative detachment, and when this detachment settles, it leaves the macular fold because of stretching of the retina and the smaller posterior segment. So there is excess retinal tissue in relation to the sclera and choroid, and this thick sclera, as we mentioned, causes the exudative detachment with a stretched retina more than the choroid and sclera. So this is the older film, as you can see. This is with my older camera. And I went in, I detached the posterior hyaloid. You can see the thick fold extending in the posterior pole, involving the macula, and working very cautiously so as not to create iatrogenic breaks in this small eye. And the posterior hyaloid was detached. Again, the same technique, injecting fluid in the subretinal space in order to have this fold stretched, and doing a fluid-air exchange, then going inside the eye again and injecting perfluorocarbon in order to iron back the retina in place and displace the fluid and the excess retinal tissue anteriorly. In this case, I did a peripheral retinotomy and removed the excess subretinal, the subretinal fluid, then did a final fluid-air exchange. And you can see at the end that the excess retinal tissue has been displaced as an inferior white crescent while the macula has been unfolded completely. So I saw this patient actually 2 weeks ago, and he has a vision of 660 in this eye after intense amblyopia treatment. So the take-home message is that prevention of macular folds is more important to be attentive of during surgery. You have to completely dry out the retina at the end of detachment surgery. Positioning of the patient, this is a bit controversial. In my hands, I leave the patient, if I have subretinal fluid at the end of surgery in the macula, I leave the patient supine and I leave a few drops of saline in the posterior pole, about 1 cc of saline. Leaving the patient supine during the first 6 hours will let this fluid press on the macula, and the macula actually reattaches nicely from posterior to anterior without folds. Some people prefer to put the patient face down or put the tear more dependent, but I believe the supine position is better by leaving some fluid over the macular area. So the technique in brief is to redetach the retina using BSS and a 41 gauge needle, fluid air exchange, ironing of the posterior retina by PFC, removing the subretinal fluid from a peripheral location, whether by 41 gauge needle or a peripheral retinotomy, while the PFC in place. If you remove the PFC first, you may have the fold reforming again. So leave the PFC until you remove the fluid from the peripheral anterior part of the retina. Finally, this is one of the pictures that we had with our dear Indian friends at our last meeting in Luxor in the Valley of the Kings. And we value and treasure very much the relationship between the Egyptian Vitreoretinal Society and the Vitreoretinal Society of India. Thank you very much.
Thank you, Dr. Hani. Next in line is Dr. Gaurav Shah, who will be speaking on topical 27-gauge vitrectomy, a useful alternative for select cases.
First of all, thank you. And Vishal, thank you for putting the early talk, because I'm like really awake and ready to go. So again, thank you for the organizers for the invitation and for putting all the effort that goes into meetings. And I know some of you have asked about the deadline for the ASRS abstracts. Don't worry, I told Jill that we're probably going to extend it. So you'll have Christmas, you should be okay. So I wouldn't sweat it. I'm going to talk a little bit about sort of anesthetic approaches in vitrectomy. This is really a simple topic, a simple talk, but I think there's some value to sort of looking at how do we do anesthetics in vitrectomy. I don't really have any financial disclosures report. The funding was done by a nonprofit that our patients donate money for us to do research. So if we look at vitrectomy surgery, we kind of 17 gauge incisions about 1.14 millimeters, 20 gauge, 23 gauge, 25 gauge, and then recently 27 gauge. So really smaller gauge surgery has sort of taken place for most of us, okay? And obviously there's a decrease in surgical time, and I think with that comes maybe a change in what we do in terms for anesthetics. So really everything in vitrectomy has changed, but our anesthesia really hasn't changed if you think about it. That we used to do general anesthesia, then we do retrobulbar, peribulbar, subtenons. So it's interesting that that really hasn't changed. We all kind of do anesthetics the same way. Maybe there's some differences how people do it, but there is an issue of decrease in surgical time. So what are the complications with retrobulbar anesthesia? Well, certainly there's hematoma, ptosis, diplopia, perforation. Important thing for the residents and fellows is the incidence is not small, 1 in 1,000 to 1 in 12,000. 30 times more likely when there's a staphyloma or they've actually had a previous buccal, right? Because that, again, changes the eye. 55% of perforations actually get a retinal detachment. So you want to be careful that if you do get a perforation. At our meeting at the Academy, the OIC meeting, our colleagues from Bascom presented this case that was just done about a month ago, but Shelley probably remembers this, that was seen at the meeting, where it shows a perforation in a patient post-cataract surgery. And you can see post-operatively under silicone oil. Here's another one through and through perforation. So these things are unpleasant when we all see them, and hopefully we don't see too many of them, okay? So this is something, one of my patients brought this to me and says, have you heard about this journal called Ocular Surgery News? I said, yeah, I kind of heard about it. So it's interesting what patients kind of bring this to you, okay? Because they're also interested in less invasive stuff, so this is sort of out there. So what's the advantages of topical surgery? Certainly it's quicker visual recovery, it's easier, might be cost effective, avoids complications of needle-related, certainly has been used for phacoemulsification, other forms of cataract, trabeculectomy, strabismus, PK, so lots of indications. So really small gauge surgery is less traumatic to the conjunctiva sclera. I think there's greater postoperative comfort, sutureless, efficient surgery. Now that we do 27 gauge, I primarily do about 95 to 97% 27 gauge surgery, and certainly 25 gauge is possible with this pretty nicely. So when do you get pain with surgery? Do you get it typically with ocular surface manipulation, endolaser, and depression, okay? So when you look at the literature, there really aren't that many papers. There's about 5 papers, okay? One on 20 gauge surgery, one on 23 gauge surgery, one on 25. And I'll show you the paper that was, that I'll have the results. This was published this year. And we think 27 gauge is perfectly situated for this. What's important to remember in these papers that were published, a lot of patients had a lot of anesthesia, sedation, right? So that you got to be careful. We use sedation. I'll go into the reasons why we did, but a lot of these patients were quote unquote snowed, right? So it was sort of on a very heavy doses of propofol. And this was one of the earlier papers, again, looking at 23 gauge, showed that this could be done, indications, hemorrhage, retinal detachment, very few patients who had macular work, and they actually tolerated quite well in terms of pain level, okay? And they use a different pain scale than what we did. And this just kind of shows you some of the findings in the paper that was first written on 23 gauge. Another paper from our colleague Dr. Azad on 23 gauge surgery showed this technique can certainly be done, but there was an issue in terms of obviously patient selection. So what we want to look at is this paper that was published this year was 27 gauge, look at our initial surgical experience. So this was a prospective observational case series, non-consecutive patients approved by the IRB. So patient selection is really critical, right? Cooperation in the office. If somebody can't open their eye to examine them, they're not a good patient, right? So the first step in fixing an eye is they have to be able to open the eye. So if they can't open the eye, that's not a good patient. And what I would typically do is if they were going to have surgery, then I actually would put the speculum in the office, lay them back, and see how they actually would do, okay? And if they didn't seem to tolerate that well, then probably that's not a good patient, okay? You could always certainly do a lid block and so on and so forth, but patients had to be consented and so on and so forth. So for the anesthetic approach, it was pretty simple. Some proparacaine and a gel about 10 minutes prior to surgery, okay? And this was done by the nurses. If needed, rescue anesthesia was available with subtenons block and controlled and so on and so forth. So patient selection, pathology of patients is key. So who did we take? We took patients with a vitreous hemorrhage from PDR, central retinal vein occlusions, retinal tears, vitreomacular tractions, submacular hemorrhages, vitreous opacities. I'm not talking just floaters. I'm talking floaters, status post scleral buckling surgery or pneumatic in the past. So these are patients who had retina problems and had persistent floaters, 1 year, 2 years, 3 years. I mean, they had 4, and this is a problem. I know that we all love buckles, but there are patients who will complain to you after the buckle that they've got lots and lots of floaters, okay? So if you look at the conditions that we excluded, retinal detachment, peeling, macular cases, extensive endolaser, and prolonged surgical time. So here's a case of a VMT. Again, there's no displacements. Typically, I don't really displace the conj. It's fairly easy to go in as long as the patient's, you're talking to them. Once a vitrectomy is done, air fluid exchange. And again, you can see these patients, they're able to help us actually when they're looking in different directions. We use a little depressor that fits on the light pipe. So it works out pretty nice. At the end of the surgery, you have them look in the direction, take the cannula out, and a little pinch of cautery over the conjunctiva, okay? And they pretty much look like this post-op day 1, okay? So a lot of these patients, now we find a lot of these patients are also on blood thinners, Eliquis, Coumadin. So even sometimes when you give a block, you know, their eye outside doesn't look great, that the family's like, what happened, right? Even though they're seeing potential, like, what happened? So we do actually have to change some of our anesthetic techniques. This is a subretinal hemorrhage. This is actually one of our fellows, vitreous hemorrhage. And then we do subretinal TP, and works again pretty well doing with this technique. Here's a patient in postoperatively. They go with a clear shield. They're able to move their eye, and they're pretty comfortable. So what did we find? Well, the mean age was about 72 years. Surgical time, 24 minutes, range of 12 to 48 minutes. Fellow participation, 90% of the cases. Fellows participated with them doing 90% of the cases. Okay, so we are big into fellowships and making sure fellows do surgery. We collected data on the most painful steps, intraoperative, postoperative, amount of anesthesia, and also adequacy of anesthesia. So we used pain level from 0 to 10, collected surgeon data in terms of control of the eye, adequacy, and so on and so forth. So mean intraoperative pain score was 2.1. No eyes required conversion to infiltrative anesthesia or subtenons. There were no postoperative complications in this group. Postoperative day 1 pain, the mean score was 0.7. There are 3 patients who did have pain greater than 2. Unfortunately, they were all 3 who had epithelial defects from the time when we had the goniosol problem in the United States. So these patients actually had an epithelial defect secondary to the goniosol. Once the defects were resolved, they really didn't have any issues. Week 1 pain score was 0 to 10 for all patients. Certainly, it was just myself and our fellow. We felt there was adequate control of the eye, and there was good control in terms of for patients. There was also interesting, there was no predictable risk factor for pain scores of 3 or higher. It's really patient's individual sensitivity. Stimuli that could produce pain in one patient could easily be tolerated by somebody else. And one of the things we looked at was IV anesthesia. Certainly we didn't use anything more than we do with retrobulbar. We actually use less. So if you look at topical anesthesia, I think you got to be careful. It is useful in selected cases, in selected patients. It will not supplement local infiltrative anesthesia, but I think it is possible to do it for opacities, hemorrhages, TPA, VMT, retained lens fragments, silicone oil, vitreous biopsy, and guess what? What's coming down the road? Drug implants, right? That's going to be the next step. So future directions will include, I think, evolution of instrumentation, improved anesthetics, maybe tissue adhesives, and hopefully we do all this because our patient expectations have really increased. So thank you very much. I want to thank our two fellows, and this paper is available. It was published in May of this year. So thank you.
Thank you, Dr. Gaurav. Can we now call upon Dr. Hemanth Murthy for his talk on surgery for myopic Schisis, trials and tribulations.
My slides, please. Yeah, so I would look into myopic foveal schisis, how has been our journey in it. And it's commonly seen, it's probably best called as myopic tractional foveal schisis. It's commonly seen in pathological myopia in about 8 to 34% patients and is caused by the tangential traction of the premacular membranes and the inverse traction of the posterior cephaloma. So I think there are two opposing forces, which is the reason why they develop foveal schisis. So some of the factors that is seen is the greater axial length, the coexistence of chorioretinal atrophy, and the interface factors actually play a role in the causation of both myopic foveal schisis and myopic macular hole with detachment. I think you can take my photograph and then, yeah, it will stop troubling me a lot. Okay, the exact cause is unknown. Primarily, there's an inner stiffness of the inner retina, and there is a cephaloma. So these are the two opposing forces. So the stiffness comes from the non-distensible ILM and the inner blood vessels, and now there is also an incomplete PVD. So I think these two factors are causing the stiffness of the inner retina. And once there is a posterior cephaloma, these two opposing forces causes the foveal schisis. The natural course is variable and the vision may remain stable for long periods of time. I think this has been the biggest problem. We do see foveal schisis, but patient is asymptomatic. So if they have symptoms, it would be metamorphopsia and blurring of vision. And this essentially occurs once there is a development of the foveal detachment. Once they develop a foveal detachment and they progress on to a macular hole, they become symptomatic. Now this is how a natural course, this is a patient who came to us first in March 2010 with a vision. He says that there's been a loss of vision and we could record a one-line drop of vision. At that time, he had no foveal detachment. Then he did come back with a foveal detachment with drop in vision in May 2011 with vision drop to 660. At that time, I had advocated surgery, but he said that this is his only eye. He refused surgery. But in December 2011, actually the retina came back, but then there is atrophy of the RPE, which caused the vision to drop less than 660. So I think at the stage of the foveal detachment is when I think best intervene, because that's the time when we get good visual outcome. Now these are various foveal schisis. Now there are some without foveal detachment, some with foveal detachment. One in the lower part you would see there is a foveal detachment. This is a patient which you definitely operate. Here there are no vitreous factors you see. Here there is a vitreous factor that causes it. So I think we need to understand where it is occurring, how it's occurring. So in which patient would just an ILM peeling be done, when you should do a just remove the posterior vitreous cortex. I think these are all based on the OCT picture. This is a patient who had come to us. Now this is in the beginning when the patients are asymptomatic. So Shimada et al. Has actually staged into 4 stages on OCT, and once they develop a foveal detachment like this, that's the time when surgery needs to be undertaken. So Shimada actually said that once the outer lamellar hole develops, then it progresses on to retinal detachment. So one should not delay at that stage, because once that starts, patients develop retinal detachment and lose vision. Surgery have been done with or without ILM peeling. I generally do most of my patients with ILM peeling, but I also do fovea sparing ILM peeling in some patients. So vitrectomy with ILM peeling, you're sure that you're removing the cortical remnants, which is very common in myopic foveous cases. And it also removes the rigid ILM. But it's always a challenge doing this in these patients because there's a chororetinal atrophy, so you don't visualize the ILM very well. So MIVS with ILM peeling, in myopic foveous cases, the studies were done, which shows that the vision does improve in most of the patients, and 96% showed an attachment of the fovea. So one of the best ways to get the initial flap would be to use, this is the loop, the finished loop that you get, which has got fine serrations at the bottom. So you see that there is a lot of atrophy, so you don't get it stained very well. And this would help you, first get the initial flap, wherein then you can start the ILM peeling, and then it becomes a lot more easier to do the ILM peeling. So I think some of the tricks would be to just get that initial flap. Then it's a fairly routine. One could do a fovea sparing. Here it's been without the sparing of the fovea. But that one needs to assess on the OCT. If the fovea is extremely thin, I think it's better that we do a fovea sparing ILM peeling. Then there have been situations wherein I have done it without the ILM peeling. Now this would be when you see on the OCT that the vitreous is predominantly the cause of traction. So Kwok et al. In 2005 showed that vitrectomy alone without ILM peeling improved outcomes. And we in a study of 112 eyes of 84 patients shows that 106 eyes, that is 95%, achieved good anatomical outcome and 75% getting greater than 2-line improvement. This is just without ILM peeling. One can see in this situation that we always have a shortage of length. So I have removed the cannula so that I get a greater length. So I've stained it with tricot. You can see that the posterior cortex is extremely adherent, and this is what causes predominantly the problem. So all that needs to be, you need to do is meticulous clearing of this posterior vitreous cortex. So you see a lot of posterior vitreous cortex gets left behind, and you need to progress and remove this. This goes right up to the periphery. And if you just remove the posterior pole, there would be a contraction that occurs in the mid-periphery which causes the retinal not to settle. So you need to remove this. So this you need to go farther. You can see that one has to be very meticulous in this step because this is where the problems come. So there have been failures that we see, especially in macular hole detachment, would be because this vitreous cortex is not cleared completely. So this would be an important step. So this is the patient, actually came to us in 2014. There was no foveal detachment, vision was 624, patient was asymptomatic. Comes again in March 2015, initial shallow foveal detachment started. I said that you need to undergo surgery. She, however, agreed only in November 2015 to undergo surgery. At that time, vision had dropped to 636. After surgery, just removing the vitreous cortex, she is fine, and the vision improved to 618. So this is just with removal of the vitreous cortex and just air injection. Now, you always find that this is a situation wherein you start the surgery and you feel that you've got the V ring, but once you stain it with triamcinolone, you would see that the entire posterior vitreous cortex is adherent at the back. This is the reason why a lot of failure occurs. So you need to stain and restain. This is one other step of ILM peeling wherein you can use a pick. I use a 26 gauge needle which I bend it very finely at the tip to give us the edge, just like the finished loop. So this would be one other step that we could use to help you in your ILM peeling. So these are some things that we need to understand. The problems are generally because of the axial length. So we have instruments which are need to be longer, and you have generally vertical. I use a 23 gauge because there is no stiffening sleeve that is present in 25 gauge. This is present in 25 plus. But if we get the 25 gauge probes, then generally they are a little longer and they allow you to have the access. We have the extendable picks. They have extendable cannulas to help you in your surgery because you generally fail to reach the posterior pole. And you can also remove the cannula so that it gives you an additional length so that you can do these surgeries. These are some problems that we always encounter. Staining is generally poor for the ILM, so we use air and then stain the ILM much stronger so that we are able to peel the ILM better. So with this, I think we have an improved outcome wherein, you need, the basic critical step is, I think, staining of the vitreous repeatedly to see that you remove all the cortical remnants. Removing the ILM actually ensures that you've removed the entire cortex because that is what helps you put it back. And I think that's the key factor in myopic foveus cases and myopic macular hole detachment. Both of them, I think, vitreous cortex removal is most important. Thank you.
Thank you, Dr. Hemanth. Next is Dr. M.R.Dogra, who will be speaking on managing complex retinal detachments.
Thank you, Shashank. Cyrus, at the outset, I would like to thank Dr. Vishali as well as the entire team for giving me this opportunity. I'm just going to talk some aspects of complex retinal detachment. As you know, this topic is vast. The major part is the proliferative vitreoretinopathy, tractional retinal detachment, which is huge itself, giant retinal tears, choroidal detachment, and some of the selected retinal detachment which happen with trauma could be real complex. Basically, the proliferative vitreoretinopathy, these are the membranes which grow over the retina and under the retina. And we also know that PVR is a major cause of failure as far as in complex retinal detachments. Basically, the PVR, either it could happen primarily, that means even without surgery, if the detachment is not tackled in time or there are other factors, or PVR in operated cases. So we all know if we have a giant tear or multiple tears, we have a choroidal detachment or a vitreous hemorrhage or inflammation in the eye, as well as long-standing untreated retinal detachment, which are often seen, or you have a posterior penetrating trauma. All these could lead to a PVR in a primary detachment. So you have a tear like this, it is left there for longer time, it may become something like this. Look at this retina, this is just a bunch, everything is closed funnel, and you have a giant tear there. So what about the risk factors for PVR in a operated eye? So this is a very important aspect. Previous RD surgery or multiple surgeries, wherever it has been done, already a preoperative PVR if it is there, or failure to remove all fractions from, I feel this is the single most. If we can't remove the hyaloid, we all know, and that happens many a times. And retinectomy and incarceration of the retina, heavy cryo, as well as a prolonged postoperative inflammation or a uveitis due to various causes. If you have a moderate PVR on early stages, try buckling surgery, but you would need a PPV in a case of aphakia, pseudophakia, no evidence of retinal break, you have a ERM causing retinal detachment or failed buckles. Basically, maybe I'm a buckler. I'm always fond of buckling. So even in a case like this where all my colleagues and fellows, they thought, I'm crazy, this can't be buckled because otherwise the retinotomy and everything has been done. But I buckled it, it settled back. So you can see even a situation like this, where is a harm? This whole band, which we would have required, pulling it out, cataract, this is just 14 years old, went back and looks absolutely fine. This is another situation, only the buckle has failed. Once buccal has failed, you may have a proliferation happening and again a similar configuration. So if you tackle in time and go back, look at this patient, how well it did, and it was 612. So what about management of a severe PVR? Severe PVR will require a pars-plana vitrectomy. I always put a band, 240 band, as well as membrane peeling, and removal of the residual vitreoretinal traction, ERM, and it has to be done very, very meticulously. And anterior base dissection is also very important here. I'm not fond of anterior retinotomy or retinotomies, or 360-degree I have done perhaps maybe a couple of times in my whole life. I think they all proliferate, they don't do anything good. And of course we need a long-standing tamponade. So for epiretinal membrane removal, you need a lot of things. So we all know that we will try peeling with everything, whether it is a bent, it's a forceps, it is a pick, you have a needle, or you require scratcher, you have a Tano scraper, or whatever. Perfluorocarbon is required in a case which is the extreme case. I'm not even showing that video that perhaps one of my fellows is going to show in other session, in the video session. So you use this as an intraoperative tool to flatten the retina. You stabilize, and it helps as a third hand. We all know, perhaps many of us sitting here are very well aware. We may have a situation like this, where redetachment would happen very soon after gas tamponade in a case, perhaps where the hyaloid was not removed, and you may have a proliferation like this. So you'll have to go in again, remove all these folds as well as the entire hyaloid, and you'll get usually a good result. And the tamponade, I think we do have evidence even from the Cochrane review that most of the time we do use silicone oil, but C3F8 may also do quite well. So prevention is very important. Remove all traction from the retina. I have highlighted this meticulous removal of the posterior hyaloid. Chase it. If you have chased it and removed it in a retinal detachment, you're not going to fail. That's what it is. And of course, you need to support the residual retina on a buccal if you are not, especially in inferior sometimes, and close all retinal breaks and do a minimal cryotherapy, and long-term tamponade would be essential. So in a situation like this is a very old video, I think 20 gauge, using a bent MVR. So it was not coming despite using forceps. So put in a triamcinolone, and once the triamcinolone was put, then only this hyaloid could be removed. This may look simple, but if you leave it here, it's going to come back to you. So once you put a triamcinolone, that's how you could remove it. So what are the recent trends as far as the RD with PVR is concerned? Perform scleral buccal initially. I've shown you one extreme case. You will do very well, especially in a young patient or a child, because I do a lot of pediatric retina. Complete membrane peeling is essential. PFCL assisted surgery may be required if you have a closed funnel. Anterior waist dissection, sometimes you require lensectomy or a IOL removal, which will be very, very unusual, rare. Use retinotomy and retinectomy rarely. Try to avoid as much as possible, and long-term tamponade is essential. I'm just going to talk about a tractional retinal detachment. In a case of retinopathy of prematurity, we have a whole lot here. Diabetic retinopathy, fever, vascular occlusion, trauma all lead to this. So we know what are the risk factors from a study which we published in 2013 in American Journal. If you have pre-existing fibrovascular proliferation or it comes up after laser treatment, here you see a case. Look at the right eye. Right eye looks, there's no proliferation after laser. But left eye has 360 degree, it doesn't look that bad. But within a week, this has just contracted over the disc. The whole retina is there, that's the way it is. So here, lens-sparing vitrectomy was done. It is a different ball game. Here, you are not chasing posterior hyaloid. Here, you're not going to go do the aggression which would be required in a PVR case. So this is what we do these days. We go only the trocar till the time it goes there, then we don't go in all the way, otherwise it hit the retina. so what is being done here, the whole retina is now crumpled over the disc. You can see there. So this was a little bit cauterized because very vascular. Now you need to look at where is the space, because here you are not going to remove you pull this membrane, whole retina will come with this. So just use that space, go in and try to make a little space for yourself. Once you have made a space, then you are good there. And with this, now slowly proceed and go and try to remove as much as possible. You can't peel here this thick membrane. Don't do that. It's going to bring the retina, and then there's another small area which could be there, and from there you try to come towards the center. And now you can see posterior pole, at least it's seen you're happy, but you're scared that I may produce an iatrogenic break. If there is an iatrogenic break, that is, the surgery finishes there and then. So as far as these retinal complicated or complex detachments, in cases of ROP are concerned, they totally require a different approach. So slowly, only this much, once you do, and after you have cut this, leave it here. You need not go beyond this, because if we go beyond this, definitely we'll end up into trouble. So this is the last bit which is being now cut there, and once this has been cut, so you can see that this is the way it looks like in the post-operative period. So complex retinal detachment with PVR, with tractional retinal detachment, these are a real management challenge. And you require many modifications, and I've shown you some. This is a complex subject, and you will need to deal, especially with the posterior hyaloid, in a very meticulous manner. Your anatomical as far as the results, they have improved. Still, I think the visual results are variable, but at times you may get a very, very rewarding results. So thank you very much, friends.
Thank you, Dr. Dogra, for a nice presentation on complex RD surgeries. Now, can I call upon Dr. Manish Nagpal for a talk on submacular hemorrhage, tips and tricks?
Thank you very much. Can I? Thank you and good morning, everyone. I'll be talking to you on an experience of various types of submacular hemorrhages, and these can occur from a very small size to a medium to a very large aggressive one. And of course, all of them have different ways of management in various situations. So these kind of hemorrhages, of course, I would most of the times do tamponade with gas and anti-VEGF, and they would come around without doing anything. Or at times you inject TPA and gas and they would come around. And these are the ones which are small to medium size and have more flattened blood in them and not a thick membrane or a thick collection of blood in these cases. But then as you go to the bigger ones, these kind of ones where there's a thick membrane also and plus a large amount of blood which is collected, for these cases, a lot of them we do surgeries from the same principles that we used to do for the removal of subretinal membranes in the past when we didn't have anti-VEGFs and PDTs. And we used to do a lot of the small classic membrane removals and the big blotches of blood at that time. So I use the same principles to do that for these kind of ones. If they're still larger, then I do a very large retinectomy, which I'll show you in the next few cases. But this is the kind of hemorrhage which has a thick central membrane well formed along with a collection of thick blood which is there. So here we would do a core vitrectomy, make sure the hyaloid is gone from that area, and then determine an area where do a retinectomy to remove the whole collection of this membrane along with the blood together. So in this situation, you need to see what is best ergonomically for you, and also you need to keep in mind the actual content and the size of what would come out, because otherwise you would increase the retinectomy size and it may cause a lot more trauma. So do a very light diathermy. I planned it along with just inside that vessel so that it doesn't damage that, and then reduce the cut rate to just 100 cuts a minute. And then it cuts like a scissor because it's totally in your control. You just press the foot switch and it'll go cut, 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 and so that you don't go beyond what
you want to go. You just control it exactly like a scissor and cut that much area. So you carefully go without obstructing that vessel and go over the diathermy area. And usually these are areas which don't bleed. And make sure after you've cut that if there is an active bleed, you could just raise pressure and remove it. And after that, this whole complex is usually collected with the membrane and the blood form clotted on it. And if you raise your vacuum very high, you will get a very good hold over it. And with today's cutters, with the tips which are very close to the shaft, it's very easy to do that. And gently, just by a rocking movement, you can just remove that whole complex which comes out through that without increasing the retinectomy. So this is something that we would do for this kind of an hemorrhage, because this is such a thick clot that in these cases, the TPA also, it may help you dislodge some of the blood, but the actual thick membrane which is there inside usually will not go from there and will leave a very thick tissue there. And then it also leads to recurrences in the future from there. So you need to keep treating them with anti-VEGFs. With this modality, you can clear it, and it usually takes care of the situation for almost a permanent thing. You don't have to give further anti-VEGFs to these patients. Very rarely would they recur. And the macula sometimes smiles back at you from there. After this, you just make sure that the residual blood is cleared from that area. Whatever is coming out from there, put PFCL so that you have a very good flatten. You can remove most of the slightly collected blood in the inferior part, which would come towards this, and do an air fluid exchange and drain that out at the end, and oppose the edges, and then do a very light laser. If it is a small membrane, of course, we don't do laser to those because they close on their own, but in this kind of a size, I do a very light laser just to the edge of that particular area. And at the end, just do air fluid exchange and gas. There's no oil required for these situations. So this is the post-op 1 month picture of that patient who's recovered 6/18 vision now. You can see this is the scar of that retinectomy which was here. The fovea is fairly good considering the thick membrane which is there, and the patient is doing fairly well since the surgery from that. Now, if you have a large subretinal hemorrhage like this, of course, a small retinectomy posteriorly won't work that effectively. And this is the other eye of the same patient. So these are patients who are prone to these large hemorrhages, the polypoidal ones. So in these cases, of course, we plan a large retinectomy in the periphery. So first of all, do a good vitrectomy. Make sure when you do these large retinectomies or even the small posterior retinectomies, the vitreous has to totally go. So make sure you stain with triamcinolone, get the hyaloid out totally, because otherwise in the long term, even if surgery has gone uneventfully, it will lead to PVRs and other contraction problems. So the vitreous has to totally go in these cases. Fortunately, most of these are older patients. They are pseudophakics or already require a cataract surgery you can remove, so that you could do a good justice to the peripheral vitreous in these cases. So here, as you can see, it's such a thick blood. Even with perfluorocarbon, it doesn't budge. It's a very thick blood which is there in these cases. So plan a peripheral retinectomy about 270 degrees, the whole of temporal, and then extending a few clock hours more on either side, so that you have enough play to evert the flap in that. Then remove the perfluorocarbon and evert the whole flap. You could use a chandelier here, you could use bimanual, whatever is convenient for you to see and feel the tissue, so that it's as atraumatic as it's possible. And then gradually evert the whole flap and expose the blood over the choroid. So this is a very thick blood. Even with TPAs and all, I've not had very good experience. They usually liquefies and then comes into the vitreous in the long term, or detaches the retina at times. So I find this more effective, that I can go and remove the whole bulk of it rather than not approach it in that manner. So once the retina is everted, you get a direct access to that whole complex of the thick blood which is there, and then you can gradually remove that whole complex from there and cut it. Once the blood is gone, then you could just treat it like a giant tear, unfold it, and you can then get a good view of what's, I mean, the whole blood complex is gone, so the retina flattens out. You can see the residue of the original membrane where the pigment epithelium, of course, photoreceptor damage is there, but then it's a much localized area as compared to the large collection of blood which was there in that case. This is the post-op pictures of these cases. A one-eyed patient having a similar disciform scar in the other eye. This eye gets about 636 or so, and the patient is stable for a long time. Of course, in these patients, we put oil and then remove it at some point. This is another example of the similar situation, a larger, thick collection of blood where we resorted to do a peripheral retinectomy. So again, the same approach, do a good vitrectomy, a good hyaloid removal, make sure the vitreous is gone in toto in these cases. And once you are sure that the vitreous is cleared, then you plan the retinectomy, and it should be enough that allows you a good play of eversion, because if you do a very small retinectomy, it would be difficult for you to evert and reach that particular area of interest. And after that, approach it the same way. You invert the flap and then remove that whole complex of blood which is there. And then put it back with a 360 laser in these cases. These are the post-op pictures of these cases. This is one of the cases which I had taken up for a similar procedure of a large retinectomy, but when I went inside, I saw these big choroidals also there, which I had not anticipated. And in this situation, I thought it's not wise to do a retinectomy. So in this case, I tried the Tamer's technique, who had suggested that inject subretinal air inside in the subretinal space, and then do an air fluid exchange and gas and leave the patient like that. So this was a large collection of blood. I would have preferred to do a retinectomy and drain, but because of the choroidals, it would get risky because these patients may go into PVRs and may have bleeding if I do a retinectomy. So I left it with a air inside, and then this patient did pretty well, because a month after he came like this with a fairly cleared up hemorrhage from the central part and regained a reasonable amount of vision in this eye. Thank you very much.
Thanks, Manish, for very beautifully illustrating the management in the various grades of submacular hemorrhage. And this is something which always confounds us, selecting the right procedure for the right case. And I think Uretina is sponsoring a big program to try and see if we can standardize this intervention. Next, we have Dr. Michael Stewart, who will be speaking to us on non-draining buckling surgery, improving the safety of an old standard procedure. Dr. Michael Stewart.
Good morning and thank you. So in contrast to much of the complex vitreoretinal surgery you've just been hearing about, I'm going to take a step backwards, and I'm actually going to reintroduce a procedure that I think has been underutilized and underappreciated in the management of retinal detachments. Current data shows that from the ASRS that the majority of retinal surgeons now do vitrectomy for the majority of retinal detachments. And part of that is our facility in terms of doing vitrectomy, increased ability, and increased improvements in instrumentation. However, many of us believe that sclerobuckling is becoming a dying art, that fellows aren't being adequately trained, and that buckling is being underutilized. Part of this is because of risks of buckling, particularly drainage of subretinal fluid. And those of us who've been around long enough fear the fact that subretinal hemorrhage can ruin an otherwise good retinal detachment procedure. Buckling, of course, has its roots way back in 1914 with Custodes, and then probably Scapins is attributed to introducing buckling on a widespread basis back in the 50s and 60s. Now, drainage had been recommended by many authors, but this article by O'Connor from 1976 showed that 50 cases of retinal detachments, non-drainage, produced a reattachment rate of 100%. And they found that 90% of the detachments were actually flat at 1 week, despite the fact that buckling was done without drainage of subretinal fluid. And what they hypothesized is that the high intraocular pressure at the end of surgery actually helps to push subretinal fluid out through the break and then subsequently improve the attachment rate forward even after the 1 week mark. So they had a 90% redetachment rate at 1 week, 100% by 1 month, and then in another 38 aphakic eyes, they found a 92% success rate where these eyes were operated on with non-drainage procedures, and their follow-up rates ranged up to 5 years. In order to understand why this works, it's important to go back to a series of papers by Michaels and Thompson from the 80s, and I draw your attention to this one. And the question here is, why does a retina detach? And the reason for this is the shape of the eye and the internal elasticity of the eye means that the retina wants to contract, and if it's released from its adhesion to the RPE, it will form a cord rather than a semicircle and detach into the center of the eye. So the traction forces are internal. How does a buckle work? We've all been taught that a buckle works by overcoming vitreoretinal traction. That is, by pushing far enough, you push the RPE up against the retina and close the break. But is that actually correct? So Michaels and Thompson did a mathematical model where they looked at the forces that are involved with A, detachment, and then B, with a buckle. And they found that by putting a buckle on, you actually change the direction of the forces. If you will, you stretch the retina over the RPE and hence take an inward force and convert it into an outward force. And so if you project this forward as to how a buckle works and what the optimal buckle is, you find that really the optimal buckle is relatively narrow but relatively high. That being said, you obviously need to cover all of the breaks in order to get the retina flat. How high is high enough? This is a judgment call. What we do want to see at the end of surgery is that the retina is indented, even if it's not flat on the buckle, though that's optimal, that the retina is indented. And by doing scleral indentation, you can actually push the retina fairly easily, even though you may not have the buckle in contact with the retina. So to address for buckle height, indirect ophthalmoscopy, scleral indentation, and the buckle, of course, has to be completely under the break so that when it's flat, you don't get fluid accumulating out of the edge of the retinal break. One other technique that has been lost over time is bilaterally patching. And patching has been performed since 1981, and under the right circumstances in eyes that don't have significant vitreoretinal traction or PVR, you can actually flatten many detachments by bilaterally buckling or patching patients over the course of 24 hours. So important points for non-drainage procedures. Careful examination is critical. You must be confident with your examination because you have to identify all breaks. And then patience and confidence are required by placing the buckle in the right position and observing patients when necessary postoperatively. So this is an excellent procedure with good postoperative rates, and it avoids the complications associated with drainage of subretinal fluid. And if you combine that with preoperative patching, I project that you can actually perform this procedure on the majority of your primary retinal detachments. So I base this on personal experience. Between 2011 and 2015, I transitioned many of my primary detachment surgeries from vitrectomies and drainage buckle procedures to non-drainage buckle. And I've gone back and done a retrospective analysis from 2016 through June of this year of my success rate with these procedures. Starting in 2016, any detachment that I thought met these inclusion criteria with primary detachment, maximum of 2 different breaks or breaks very close to each other within a clock hour, and a minimum follow-up of 3 months. However, the media had to be clear, and I wanted to avoid eyes with fixed folds. So of the 39 eyes that I operated on with primary retinal detachments during that period, 20 or 52% met the inclusion-exclusion criteria. And I performed the buckling surgery anywhere between 0 and 5 days after the diagnosis. 14 of 20 were general anesthesia. All surgeries were done as outpatient. 3 patients were bilaterally patched prior to surgery, in order to allow some resorption of very highly elevated subretinal fluid. My technique, I preferred to use a radial 2.75 by 7.5 millimeter sponge. I think this gives an excellent push. I have done some surgeries with the 2.5 by 5 sponge, but quite frankly, I've been a little disappointed, and I'll talk about those. And then when necessary, a short circumferential segment of a 287 tire is important when you have multiple breaks very close to each other. So here are the baseline demographics of my cohort. You can see that age, sex, etc. is fairly typical. The duration of the detachment, anywhere from 1 to 14 days. Macula on in 70%. Most of these patients presented quite early. The mean visual acuity was 20/50 in this series from 20/20 to count fingers. And here were the final results. All 20 patients were attached at final follow-up, which ranged anywhere from 3 to 25 months. 18 of 20 were flat or nearly flat day 1 post-op. And by nearly flat, I mean the breaks were completely flat, but there was mild residual subretinal fluid which had not yet completely absorbed. In 2 of the patients, both of whom I had used the 2.5 by 5 millimeter sponge, there was as much fluid on day 1 as there was prior to surgery, and quite frankly, I didn't have the patience to wait them out, so I put 0.3 cc's of air into those eyes, and they flattened completely and were successful at the time of final examination. The visual acuity final exam was a mean of 20/25, with the worst eyes being 20/60. Complication rates were very low. 2 patients had diplopia, both of which was transient, and they resolved 7 to 28 days later. Delayed absorption of subfoveal fluid in 1 patient persisted for 2 months. I didn't do anything, waited that, and that completely resolved. No patients experienced extrusion of buccal, and no patients had increase intraocular pressure. So here are 2 sample patients. Here's a patient at baseline, and you can see the area of subretinal fluid here, infratemporally, with a break down at about 4 o'clock. Not an ideal candidate for pneumatic retinopexy, though one could have attempted it. This patient had a 7.5 by 2.5 millimeter radial sponge, and on day 1 was completely flat. Here's a second patient with a nasal detachment extending back to the optic nerve. This patient actually has 2 breaks within about 1 clock hour of each other. So in this patient, I put a 287 tire component tied tightly with 2 sutures, did not drain, and here the patient looks 1 day post-op with the breaks completely flat and a very small amount of residual fluid at the posterior edge of the buccal, which resolved by 1 week. So in conclusion, in this cohort from 2.5 years now, 100% reattachment rate with a single surgery, albeit 2 patients had supplemental air injections at 1 day post-op. There were no long-term adverse events. The safety advantages to surgery: this does not induce cataracts, as in contrast to vitrectomy surgery, and it avoids the risk of subretinal hemorrhage that we all know is associated with drainage procedures in sclerobuckles. So for primary retinal detachments, I no longer do pneumatic retinopexy. Even though that's a good procedure, I hate the idea of reoperations, and I know that even under good patient selection, I'm going to have reoperation rates with pneumatic retinopexies. And for primary detachments, if they fit these criteria, I don't do primary vitrectomy all that often. I tend to do non-drainage buckles or drainage buckles if they fit the criteria. So thank you very much for your attention.
Thank you, Dr. Stewart, for a very nice presentation and for emphasizing the importance of reviving the dying art of scleral buckling. I think it's always something which is very welcome. Next, we have Dr. Marc de Smet. Is Dr. Marc here? Next is Dr. Manisha Agarwal, who will be speaking on managing persistent macular holes.
A very good morning to all of you, and at the outset I thank VRSI and Dr. Vishali for giving me this opportunity. I would be speaking to you in the coming next 10 minutes how to go about managing persistent macular holes. Now, how do we define a persistent macular hole? It's a hole which remains open after the primary macular hole surgery, with the absorption of the gas tamponade, or maybe 2 weeks after you have put in a silicone oil tamponade. And this is a complication we encounter in about 10 to 12% of the cases. The various causes which could lead to a persistent macular hole could be a very large primary hole, persistence of a vitreomacular traction, inadequate or an improper ILM peeling during the primary surgery, insufficient tamponade, or the non-compliance to the prone position by the patient. Well, before we decide for a resurgery, there are certain favorable signs which we can look for when we do an OCT. This could be a persistence of a VMT which favors a resurgery. We can also look for the edges of the macular hole, and if they're found to be like sloping edges with cystoid changes, it's again a favorable sign. And factors like presence of subretinal fluid, no thinning of the retina, an intact ellipsoid zone, and a healthy RPE at the base of the macular hole, they all favor a repeat surgery. However, resurgery is best avoided in patients who show up a RPE atrophy, which we usually see in post-traumatic holes, myopic macular degenerations. If the patient says, I'm not able to maintain a prone position, you have large holes which are more than 1,000 microns. But what we need to remember is the time of intervention, which is very important to achieve a higher chance of anatomical closure. The timing of resurgery is usually about 4 to 6 weeks after the primary surgery, but what we need to assess is if there is no effective gas tamponade or 2 weeks after silicone oil tamponade, then it's unlikely to close and we can plan a resurgery. However, if we do a serial OCT which shows a narrowing of the hole with progressive approximation of the edges, then probably we may wait a little longer. Now let's come down to the various surgical techniques for persistent macular holes. So in most of the cases, if we see a hole like this, which has a drawbridge-like edges with cystoid changes, presence of subretinal fluid, then probably just a fluid air exchange with a gas tamponade and a strict prone position can help us in achieving a closure of such holes. But what we need to really ensure is the complete removal of the residual posterior hyaloid phase and that no ILM is left till the arcades. This is my first case of a post-traumatic macular hole, a 26-year-old young male patient post-firecracker injury and has a very poor vision. As you see, there is an extensive retinal thinning, and we actually counseled this patient against a resurgery, but he was very disturbed with a scotoma. So this is a case which was operated about 5 to 6 years back, where we really didn't know how to approach these patients. And the simple thing we did was that with a soft tip cannula, we just went about loosening the retina all around this macular hole. And you see there's already a pre-existing RPE atrophy, so we were not much concerned. And we knew that the visual prognosis were poor. And if you see the post-op, this hole actually closed just by this simple procedure. And the patient apparently felt better and said that the scotoma apparently had reduced. This is my second case, an obese female. She's already undergone 2 surgeries, but she's still having a persistent hole. And in this particular patient, we actually just peeled whatever shreds of ILM we could find around the persistent hole. It was a mixture of the ILM along with the ERM, and we just stuffed in a combination of this ERM flap along with the ILM into this macular hole. And again, you see, we did get a type 1 closure, and she did show a marginal visual improvement, and the hole closed beautifully. This is my third case, a 65-year-old female patient, again has undergone a primary macular surgery 1 month back. She's still having a persistent hole. Her vision is 636, N36. Now this is interesting because apparently I could not find any ILM at all around this macular hole, so we went on the temporal side. You see that the ILM is very much stuck over here. So we could leave this particular edge, which was very much adherent, and we just lifted this entire ILM and just inverted it over the macular hole. Here we did not even have the risk of dislodging this flap because it had one edge which was attached, so it was like a hinged flap, and we went ahead, did a fluid air exchange followed by a gas tamponade, and this is how it appeared, something like a whole inverted flap over the macular hole. The hole again showed a type 1 closure, the vision improved to 618 and 12, and the patient was quite happy. This is my fourth case, a 60-year-old female patient, again with a vision of finger counting, 2.5 meters, macular hole surgery done somewhere else 6 weeks back. This is how the hole is. So this patient, apparently we planned a free ILM flap. We first removed all the shreds of the ILM that you see. So they were all removed from around the macular hole. We lifted up one edge of the ILM. We did not completely detach it. We placed a perfluorocarbon liquid bubble over the posterior hole. And finally, we detached this flap under the LPFC and gradually dragged it over the macular hole. Now, one needs to be a little careful in such situations because it's a free flap. There's a very high chance of losing this flap when you do a fluid air exchange. So after you have got the flap over the macular hole, you have to just tuck it into the edges of the macular hole, followed by a very careful fluid air exchange, keeping your flute at the nasal edge of the optic nerve head. So this is something what we did. We tucked in the edges, and this was gradually then followed by a very careful fluid air exchange. And again, we got a good closure of the macular hole, and the vision improved to about 636 N24. I thank Dr. Hani. This is his case, which I have borrowed from him because I don't have any personal experience with this technique. This is a patient who's undergone 2 surgeries, a primary vitrectomy with an ILM peel, followed by a silicone oil tamponade. You see that the hole is very much persistent and open. This patient again undergoes a 3rd surgery with a free ILM flap, but hole is again quite stubborn and is not tending to close. So here Dr. Hani plans a full thickness retinal graft. So we apparently do a barrage in either the supranasal or a inferior nasal quadrant. With a 41 gauge cannula, the cell line is injected to detach the retina within the barrage area, and a small flap of the retina is then dissected out. Now one needs to be careful that you don't lose this flap and it is placed straight over the macular hole because you want the photoreceptor layer to face the area of the RPE. Now you'll just notice that when the LPFC was placed, that whole flap just got sucked into the flute. So again, another area was chosen. Again, a small area of the retina was detached. A small graft again taken off the retina. LPFC was injected. And this flap was again placed over, I think a better term would be to use a graft, which was placed over the macular hole. And this time, Helon was injected to keep the graft in place. And gradually, the LPFC was removed, fluid air exchange was done. And more Helon was injected so that the graft remains in place. And something interesting what Dr. Hani told me was that you keep the patient supine for about 6 hours till the graft is very much stuck there, and then you make the patient to lie supine, prone.
Yeah.
So OCT, after 8 weeks of insertion of the full thickness retinal graft in the macular hole, you see there's a good anatomical closure with very marginal improvement in vision, but we have achieved an anatomical closure. The other options for a persistent macular hole could be something like an anterior capsular flap, where you are doing a combined surgery of phaco and a macular hole surgery. Again, these are videos which I have borrowed from Dr. Mahesh Shanmugam. I thank him for that. And the other option would be to put in an amniotic membrane graft for situations where you don't have any ILM left to stuff into your macular holes. This is my last case of a high myopic patient with a full thickness macular hole which is persisting with a retinal detachment. The axial length is as high as a 30 mm, the BCVA as low as counting finger, and these are cases which are not really going to close with just a simple vitrectomy and a gas tamponade, and the only option would be to do a macular buckle. This is again a patient which has been managed by Dr. Padmaja from LVPI, and this is a macular buckle which is placed under the lateral rectus muscle, and it provides an excellent indentation to overcome the problems of both the macular hole and the posterior staphyloma. And if you see, there's a beautiful closure what you get. There's a very good indentation that you can appreciate under the macular hole. You have a good closure of the macular hole, and the vision has improved from counting finger to about 160. So what I conclude is that there are several options available for closing the persistent macular holes, and probably we just need to persist with persistent macular holes. Thank you so much.
Thank you, Dr. Manisha, for comprehensively covering the topic with the whole spectrum of options we have. Now, can I call upon Dr. Cyrus, please, for presentation on management of severe PDR, tackling and ticklish anterior extension.
Thank you, Dr. Shashank, and thanks to VRSI for having me as part of this wonderful session today. In the next few minutes, I'll be speaking to you on one of the ticklish problems which we encounter when doing diabetic vitrectomies, and that is very anterior extensions of the fibrovascular membranes which we often encounter. So PDR, the correct term would actually be a proliferative diabetic vitreoretinopathy, and what differentiates it from simple PVR is that there are vascular connections between the retina and fibrovascular tissue, the vascular nails, hemorrhage, and vitreoschisis. So a general principle for any dissection is that you should be in the correct plane, and being in the correct plane makes a difficult case simple, and an incorrect plane can make an easy case tough and messy with intra and post-operative complications. And to find this correct plane, you have to be very aware of the phenomenon of vitreoschisis, which is almost universal in these cases. So this is the classic diagram which Schwartz et al. Where we demonstrated that what was looking as the subhyaloid space was actually the Schisis cavity, and this is the true subhyaloid space. So you have to find this plane to be in the correct. This little animation shows how this plane gets created. We have the vitreous hemorrhage occurring from the proliferation, which tracks and forms the vitreoschisis cavity, creating anterior, Can we go back on this? Yeah, so this creates the anterior and posterior leaf of the vitreoschisis, and once the anterior leaf contracts, that produces a traction retinal detachment. Now this shows as this proliferation proceeds, you can get either various configurations of the fibrovascular tissue, the C pattern, or you can get an entire area of a tabletop traction retinal detachment, or in some situations you can get localized areas of proliferation extending, which can then produce these anterior extensions, which can sometimes go extremely peripheral, as we'll see in the next few videos. So here we see this is the anterior extension going here, and it's important that we disconnect the hyaloid peripheral to this. That's extremely important, because otherwise if you're doing a dissection here and not disconnecting, you'll be leaving tissue there and produce problems in the post-operative period. So once you have that edge created in the periphery, which often you can do with the aid of scleral depression, then you can proceed with the rest of the dissection. This was another case. Now, fortunately, many times these anterior extensions tend to be localized. So the rest of the separation occurs here. As you see, the retina also looks fairly healthy, but you have this localized area. We see this most commonly either in the inferior temporal or in the superior nasal, as we'll see in the next video. And this then, but you cannot leave this tissue here. This is adherent right up to the periphery, and it's important that we remove this fibrovascular tissue. So here we use a bimanual dissection, and we are working now from posterior to anterior with both the cutting and the shearing action of the scissors. We see this rather thick tissue being removed. But this was again adherent, so here we see the working the other way around. Here the cutter is on this side, we are holding it with the forceps and finally disconnecting the last part of this fibrovascular tissue from the periphery. Again, opening the conjunctiva is important. That helps you to get scleral depression, and that does help a lot, and the case ends up with the fluid-air exchange. This was another case. Here you see this, the rest of the separation of the hyaloid has happened. We've removed all the blood, but again there is this extension proceeding very, very peripheral. It's virtually right up to the aura here. And again, it's important that we remove this tissue entirely. We can't leave this or just segment it and leave it either. So to remove this, we initially started from here you see when with depression, the extent of the anterior polyp. We started from the posterior pole, again using a bimanual dissection. We could come up to a certain point, but beyond that, you're working in the wrong direction. So that's not your angle of sight. You're getting your view gets obscured by the fibrovascular tissue itself. So beyond a point, you can't work from the posterior to the anterior. And here, again, using spiral depression now, we are trying to get the anterior edge of this and trying to separate it from the retina. It's still not separated, so you see you have to dissect this. We finally got the edge now, and using the scissor, sometimes we use it and turn the scissor 180 degrees to get the point down, which helps to work with it more atraumatically and not damage the retina. And finally, you see this extension coming here peripherally, and we are able to cut that away. And now that entire edge got freed from the periphery. And once that happens, then the dissection now, you're proceeding from anterior to posterior, and then this last part is quite easy now. You can see each connection and remove that entire tissue from the retina. Once that happens, the retina is mobile. None of the fibrovascular tissue is now left there, and we conclude the case with a fluid-air exchange and gas. In most of these cases, we generally prefer to use gas rather than silicone oil. It generally gives a good tamponade. Pressures tend to be better in the post-operative period, and the problem of sub-silicone oil bleed and reformation and proliferation of membranes tends to be less if we use gas rather than silicone oil. Thank you for your attention.
Thank you, sir, for the great presentation. Can I now call upon Dr. William Miller for his presentation on controversies in management of macular holes and vitreomacular adhesions.
Thank you very much. It's a pleasure to be here, and thanks for the invitation to partake in this symposium. I have no financial disclosures pertaining to this topic. 25 years ago, it was first reported that we could actually do surgery for full-thickness macular holes. Kelly and Wendell reported 14 cases, successes in 8 or 57%. Over the past 25 years, we've had dramatic improvements, but still some controversies. We have better surgical techniques, smaller gauge surgery. We manipulate the ILM better. And of course, we have differences in how we stain tissues, and the duration and use of our gases are all somewhat controversial. So we're going to talk about a couple of topics. First of all, lamellar macular holes, and a concept called lamellar macular hole with epiretinal proliferation. Then we'll talk about full thickness holes, and finally talk about vitreomacular adhesions. So once again, options for macular holes. Observation works very well for most lamellar macular holes. Then we'll talk about surgery for the full thickness holes. About 4% of patients have a lamellar macular hole. Most patients do great. They have reasonably good vision, and natural history is really quite favorable for stable, prolonged situations. But are there features that we look for that might predict a greater chance of things worsening? The answer is yes. But first of all, a report earlier this year showed that over a 5-year time frame, most patients really do very well, and only a small percent of patients actually go on to requiring intervention. Things that we look for, though, are mainly prognostic factors on OCT testing, whether there's a large basal diameter, as you see here, very thin retina, presence of epiretinal membranes or proliferation. And of course, if there's disruption of the ellipsoid layer, those patients tend to do not so well with natural history alone. So these factors will lead us to a greater chance to recommend proceeding with vitrectomy surgery. Long-term follow-up study with patients that had these features once again shows surgery can be successful. Most patients end up with 20, 30 or so vision 3 years after surgery, and a small number of them do decrease, but most of them have a favorable outcome. So when patients have these features on OCT, they can do well with surgery, but keep in mind that most patients with lamellar macular holes can do very nicely with just observation alone over a prolonged time frame. Now, a couple of years ago, Pang, Freund, and Spade reported this concept of epiretinal proliferation with lamellar macular holes. It's a bit different than an epiretinal membrane. It's defined by 3 parameters: an irregular foveal contour or defect in the inner fovea, as seen on this patient here, thinning of retinal tissue at the base of the fovea, and finally the absence of a full thickness defect. So when this is present, these patients oftentimes have a little bit of a worsened outcome, and these findings lead more commonly to the need for vitrectomy surgery. With surgery, most patients can do very well. With removal of this epiretinal proliferation, they can have stabilization and closure of their lamellar macular holes. They don't favor quite as well in the setting of high myopia, but still these eyes can do quite well when they have a highly myopic scenario with a lamellar macular hole. So to summarize once again, when we see this epiretinal proliferation concept with a lamellar macular hole, oftentimes these patients will go on to require surgery, but can do very well. So look for these features on SD-OCT testing, and if present, these patients probably monitor a bit more careful long-term follow-up and a greater chance to go on to requiring surgery. Let's evolve into full-thickness macular holes. Once again, 25 years ago, we watched these eyes. Today, of course, we have surgery, over 90% success rate in this scenario. Almost all patients have removal of the ILM. We stain most times with ICG or trypan blue. We oftentimes use this inverted flap technique, especially for larger holes or holes that are associated with myopia. In terms of tamponade, we've gone away from the long-acting gases now, oftentimes just to a single bubble of air with maybe 3 or 4 days of positioning. This, of course, is the ideal scenario where you have a full-thickness hole, stabilized anatomically with improvement of visual function. Now recognize that while most of us peel the ILM very routinely, a couple of papers have shown that it probably isn't necessary, especially if the hole is not very large in size, but recognize that surgery does cause some degree of trauma around the base of the hole as well, but for the most part, we peel the ILM. We, in most cases, stain with a dilute concentration of ICG. In the United States, we don't have access to the different blue dyes, brilliant blue or trypan blue. They're not FDA approved, but we still can access on occasion. Most of our patients have ICG staining. I personally will use the inverted flap technique when I have a large macular hole, usually in excess of 400 microns, or in patients with high myopia. It's a technique that now has about 4 or 5 publications describing success rates that are comparable to these smaller sized macular holes. But this technique is really not essential in most of our patients, but recognize it can be a nice adjunct in patients who have larger holes or holes associated with myopia. So once again, a number of papers have shown quite nice that this can work very readily in those settings in particular. Tamponade agent, once again, we've gone away pretty much from the long-acting gases. We recognize that even a short duration, 3 or 4 days of tamponade face down, can lead to success in most patients. So we've gone away from the long-acting gases, and most times patients require just 3 or 4 days of face down positioning. In my setting, oftentimes we do combine cataract surgery, therefore the risk of causing cataract is not a concern, but still have my patients in most cases go with air tamponade and maintain face down for 3 days. All these things have potential complications. If you look at OCT testing, you can see intraretinal abnormalities with vitrectomy surgery and with peeling, so just recognize that most times these features probably have very little impact on outcomes, but there is damage done to the retinal surface when we do peel and or remove the ILM. So once again, does not come complication-free. A number of reports have shown this quite readily. Now I have to talk a bit about ochraplasmin. That, of course, is a non-surgical alternative to macular hole surgery. Introduced 5 years ago, January 2013. It's an office-based procedure. It's a truncated form of human plasmin. and it basically cleaves, has a proteolytic effect on fibrinogen, fibronectin, and to a lesser extent on laminin as well. So it potentially can solve a macular hole in a non-surgical fashion. Here's a case treated with ochraplasma alone that closed the hole and had a successful anatomic outcome. Now, the studies that were done, the MIBI studies, showed about a 40% success rate, which is nowhere near our 90+% success rate with surgery. If you choose your patients carefully, smaller sized macular holes, you can have a more favorable outcome. If the patient's relatively younger, smaller sized hole, absence of epiretinal membrane, and is phakic, you can get up to maybe about a 50 or 60% success rate in this setting. Is it safe? We're all concerned about some issues that have arisen in terms of transient and even in a few cases of permanent visual loss. But for the most part, most features or most abnormalities are short duration, less than 1 week. These were complications noted in the MIVI clinical trials. Once again, most are transient, but there are a couple of patients that did have permanent visual loss where there was disruption of the ellipsoid layer in the adjacent region to the macula. Post-MIBI trials, once again, transient problems have arisen, but I think for the most part, we accept now that most patients do well and are relatively free of complications. You have to ask then, is it cost effective? If you look at success rate, the cost of the procedure, and the amount of vision gain back, it actually turns out that vitrectomy in the study done by Smitty and Chang was actually more cost effective than ochraplasma. So you have to factor that in mind as well. While there's less expense up front in terms of quality vision afterward, perhaps the vitrectomy surgery is still more favorable. So to summarize, macular holes are very commonly employed. We've gone from large gauge surgery, we now stain routinely, we tamponade shorter duration, and these patients can oftentimes do very well. Our use of ochraplasma is certainly not real common, but just keep in mind it is an alternative to the use of vitrectomy surgery. In my last couple of minutes, we're going to talk briefly about this issue of vitreomacular adhesions. Now, is this much different than a macular hole? Well, keep in mind that the options here are very similar. You can observe, you can use ochraplasma, you can use pneumatic vitreolysis or vitrectomy surgery. The presence of a membrane, even as bad as this, does not warrant surgery unless the patient is symptomatic. This patient, amazingly, is 20/30. And here's that patient a year apart, still 20/30, 20/40. This separated spontaneously, and the patient actually flattened that region and did very well. Ochraplasma has been touted as an alternative treatment for this, and once again has a similar array of concerns, the complications I mentioned with full thickness macular holes. You can get about a 25% success rate in the MIBI trust trials. The OASIS trial done afterwards showed about a 40% success rate compared to sham, so it works, but not in every case. The concerns, once again, are very similar to what we talked about with macular hole surgery, transient visual disturbances, which for the most part are transient. Well, there's also one other potential issue, that is, do these patients do well from the standpoint of the VFQ-25? And the answer is yes, they have improvement. Has this been shown to be beneficial in meta-analyses and Cochrane database reviews? The answer is yes, to a limited extent. But recognize that also we can just do pneumatic vitreolysis. We can, between 57% of the time, achieve a separation by injecting an air bubble in the vitreous cavity. So to summarize vitreomacular adhesions, we have options ranging from observation to surgery to ochraplasma to the use of an air bubble. Recognize in the United States, the DRCR net is going to have a study very shortly looking at the use of a pneumatic approach to this condition. So controversies remain, but we've had a lot of progress over the past 25 years. Thank you very much.
Thank you, Dr. William. Now for the last talk of the session, I call Dr. Urmi, who has replaced Mr. Suresh, for the talk on future of retina. What next?
Thank you, Dr. Shashank. Firstly, I would like to thank the entire organizing committee for giving us this opportunity to share our strength, the pipeline with Novartis. Dr. Menon couldn't be here, so I'll be presenting on his behalf. So, the future of retina, what next? Our ophthalmology franchisee forms a new world-leading business that offers patients one of the broadest portfolios of ophthalmic medicines, treating the front and the back of the eye. So the range of intravitreal therapeutics available to the retinal specialist for treatment of chronic retinal diseases today including age-related macular degenerations, DME, RVO, and posterior uveitis, has continued to expand significantly, providing excellent options for improved visual acuity and quality of life outcomes. Ophthalmologists are well aware of the limitation of such therapeutic approaches, and novel compounds and innovative delivery systems are being investigated to make existing therapies more effective. Our global drug development is a large-scale and world-class development organization with about $4.5 billion pumped every year for research and innovation, engaging about 10,000 associates, 200 programs run in clinic with 90 new molecular entities established on a yearly basis, with one regulatory submission every 6 minutes. About 530 clinical trials, active trials running with 80,000 patients in 70 countries are being done, and we do take our adverse event reporting very seriously. About 850,000 pharmacovigilance cases reported every year. The Novartis ophthalmology development always revolves around innovation. So developing innovative treatments for diseases of the eye, addressing unmet patient needs. Also in the front of retina, we have our next new brolucizumab RTH258 coming in. We drive innovation through glaucoma as well as dry eye, through new mechanism of action, through innovation within the current portfolio, and further accelerate innovation through external opportunities as well. We have development sites all across the globe, with one of the largest development sites here seated in India at the Hyderabad Global Office. Novartis has had a broad portfolio of leading in-market brands for retina. Example is Centis, which is ranibizumab, also known as Accentrix in India. Glaucoma, example Travitan, Travoprost, for external therapies such as Systane. We also have a strong late-stage retina pipeline, as I mentioned, RTH258, and promising early-stage research for the treatment of glaucoma, presbyopia, and otic disorders. However, this slide deck only has products which are ophthalmology-related. So Novartis is committed to addressing the unmet needs of current vision healthcare, and we aim to achieve this through breakthrough innovation. So the need for effective therapies in NAMD, age-related macular degeneration, as we all are aware, is a common cause of visual loss in the elderly, with increasing prevalence due to increasing life expectancy. While the introduction of anti-VEGF therapy has improved outcomes, and there has been still major unmet needs and gaps in the understanding of underlying biological processes. So here, addressing the unmet need, despite improved outcomes, new treatment options are still required to address these. Neovascular age-related macular degeneration is the most common cause of permanent central visual acuity loss in persons over 55 years of age in industrialized nations today. And intravitreal vascular endothelial growth factor inhibitors are the mainstay of NAMD treatment worldwide. Anti-VEGF therapies are proven to resolve retinal fluid and improve visual acuity in many NAMD patients. However, challenges still exist in the treatment of NAMD, and Novartis is committed to meeting these challenges. Novartis' strategy for addressing the unmet needs of NAMD treatment include, firstly, to reduce the treatment burden, secondly, to improve efficacy, then provide treatment options that maintain BCVA gains in the long term, and of course, the most importantly, is to improve quality of life. With that, let's go to brolucizumab, the RTH258, and also known as ESBA1008, is a novel intravitreal anti-VEGF agent developed by Novartis for the treatment of NAMD. Brolucizumab is a humanized single-chain antibody fragment that binds to and inhibits all isoforms of VEGF-A. Preclinical studies found that brolucizumab was well tolerated in non-human primates. Brolucizumab is the smallest anti-VEGF molecule tested in humans to date, weighing about 26 kilodaltons. In contrast, currently anti-VEGF agents range in molecular weight from 48 kilodaltons to approximately 149 kilodaltons, that is ranibizumab and bevacizumab respectively. The early phase 1-2 study demonstrates longer duration of action of brolucizumab. That was the first phase 2 study investigating the efficacy and safety of brolucizumab compared to ranibizumab. Results showed that brolucizumab 6 mg was non-inferior to ranibizumab 0.5 mg in reducing CSFT from baseline at month 1. A single 6 mg dose of brolucizumab also achieved a longer duration of action compared with ranibizumab 0.5 mg, here shown in the graph. The treatment interval for brolucizumab 6 mg was 30 days longer than ranibizumab 0.5 mg, supporting the longer duration of action of brolucizumab. So study C12-006, the Osprey, a phase 2 study comparing the efficacy and safety of brolucizumab with aflibercept, 6 mg and 2 mg respectively. Subjects, which were 89, were randomized in a 1:1 fashion, brolucizumab or aflibercept groups, each receiving loading doses at baseline, week 4, week 8, and matched once every 8 weeks. Treatment cycles at week 16 and 24-32 respectively. And the primary endpoint was week 12, secondary endpoints was at week 16 and 40. Brolucizumab here also proved to be non-inferior to aflibercept at week 12 in terms of BCVA, change from baseline, that is the primary endpoint, and numerically greater and more stable reduction was seen in CSFT from week 16 to week 40 relative to week 12 with brolucizumab versus aflibercept. 61% of brolucizumab treated subject versus 35% of aflibercept treated subject displayed complete resolution of retinal fluid at week 40. 15 versus 6 rescue injections for aflibercept versus brolucizumab were respectively given during masked head-to-head 8-weekly dosing comparison. And no differences in safety profiles were observed between brolucizumab as well as aflibercept.
One moment, I just interrupt. After this, we are going to have a panel discussion and a question-answer session, so I would request people to please stay on for that.
Then came the phase 3 study, which is our two parallel phases, phase 3 registration studies, that was the Hawk and the Harrier. So Novartis is currently conducting 2 phase 3 trials assessing the efficacy and safety of brolucizumab in subjects with NAMD. And these are Hawk and Harrier, and both trials are fully enrolled and also complete by 2018. So this is the basic design, which was to assess the efficacy and safety of 12-weekly dosing of RTH with the 3 monthly loading doses, and then versus 8-weekly dosing of aflibercept. For both the studies, just to let you know, Hawk was a 3-arm study where 3 mg and 6 mg of brolucizumab were tested versus an aflibercept of 2 mg, and Harrier was a 2-arm study, which was just the 6 mg versus the 2 mg of aflibercept. So RTH258 met the primary endpoint with majority of patients on 12-weekly dosing, and currently DME and RVO studies are planned. We're already started enrolling patients for the DME study. So the primary efficacy with change in BCVA from baseline to week 48 was achieved, and secondary endpoints were also achieved with a maintenance of 52% to 57% proportion of 12-weekly subjects to up to week 48 in the brolucizumab treatment arm. This was lately presented at the ASRS this year in July. So to summarize brolucizumab, the key findings at week 48, firstly, it was non-inferiority in BCVA versus aflibercept, with a majority of patients maintained on 12-weekly interval. Significantly less disease activity at week 16 was seen, a superior CSC reduction at week 16 and 48, and significantly fewer patients with presence of IRF and SRF at week 16 and 48 were checked. Fewer patients with sub-RPE fluid at week 16 and 48, and overall ocular and non-ocular adverse events rates for brolucizumab were comparable to aflibercept. This was the latest press release we had in June 2017 regarding the primary endpoint, meeting of the primary endpoint. Next, we come to the ranibizumab port delivery system. This is still under study, and prolonged passive delivery is something that we want to achieve. The RPDS is a non-biodegradable device which is inserted and anchored into the sclera through a surgical procedure to slowly release ranibizumab over 4 to 6 months. Positive phase 1 data is with acceptable safety and tolerability, and efficacy trends have been seen, and phase 2 study has been started in the US only. On gene therapy, Novartis is committing to using innovative scientific directions to tackle inherited retinal diseases such as retinitis pigmentosa. Gene therapy refers to therapeutic delivery of nucleic acid polymers that act to modify the cellular transcription of defective genes in patients with genetic diseases. The nucleic acid polymers are typically delivered using genetically modified non-pathogen viral vectors. During infection, viruses introduce their genetic material into the host cell DNA, tricking the host cellular machinery into using it as blueprints for viral proteins, and scientists exploit this by substituting a virus genetic material with therapeutic DNA. moving on because of the time shortage.
Yeah, I think we'll have to wind up.
Okay.
Dr. Venu.
And lastly, so I would like to conclude with CLG 561, a treatment option for geographic atrophy. That is also something that we are looking at. Thank you.
Thank you. Thanks a lot. So I think the gist of it is that we have a promising new kid on the block, the brolucizumab. So let's see what the results with that are going to be, and seems promising, and when it becomes available. So now we have the panel discussion and the questions. I'd invite Dr. Anirudh Agarwal, Dr. Suresh Babu to come up to conduct the panel discussion, and I'd invite the panelists, Dr. Judy Kim, Dr. Manoj Khatri, Dr. Ajit Babu Maji, Dr. Natarajan, and Dr. Giridhar. As they're getting going, I had just one question from Manish. Very interesting procedure you showed in which you made that incision along the arcade. It's actually the first time I've seen that. And so what made you make that large incision? I mean, couldn't you have got that out even if you were making a posterior retinotomy through a smaller incision? As we had seen in the submacular surgery era, the retina is elastic and tends to kind of allow large clots to come out through fairly small looking openings. So
Yeah, I mean, as I said in the past, we used to remove a lot of these, and that's what, gives us that idea to do this for these kind of cases. But this is a larger chunk. As you saw that when it came out, that size, if suppose I had done a smaller one, it would have stretched, or it would have caused a lot of resistance and then whatever retina gets traumatized or like that enlargement happens is not in my control. And it's fairly close to the fovea. So I think in the past, having done a lot of these different size ones, I realized that sometimes I've had to struggle to get it out. So now I make a slightly wider one, make it a little curved so that lesser tissue is damaged. If you make it straight, then you'll probably have to make it larger. So if you give a little smiley kind of a thing, then you get more surface area to get it out from there. So as away from fovea as you can get, but then you need it in a place where you can get a good hold right under it on the whole complex.
So I have a comment on the same thing as that was really nice smiley face that you were talking about. I do agree that if you make your own incision, you'll be less traumatic, less tearing, especially in that large complex that's already formed into a discal scar in a way.
Yes, exactly, yeah.
Why did you decide to do it inside the arcade rather than outside the arcade?
Yes, so that's what I said, that
you might be able to
it
not
has to be
damage.
done where you can, the complex is just right under and not after it's ended, because then to insinuate your cutter and all is more difficult. Then you need, like in the past we used to remove smaller membranes with the subretinal membrane forceps, but then this will not work like that. You need a better hold to bring it out, and a good vacuum from the suction cutter is great. And since we don't have curved cutters or anything going insinuating, you need it where you can get a good foothold on that.
Because other ways you could actually inject some subretinal fluid, PSS or something, so that you actually detach partially and then make that.
Yes, you could make a detachment and then also,
Yeah, I think what she suggested is a very wise thing, but because the arteries we can save, so that the perfusion to the central macula will be intact. Otherwise, you will be compromising two major branches of retinal artery.
Absolutely.
Advantage of doing diathermy is to lessen the bleeding, but you are compromising the blood supply to the center of the macula. So it's a good modification, and with a good subretinal forceps, I think it can be done very nice.
Sure. No, the other issue with this is like when you're taking away the membrane, it strips some of the RP.
Yes.
So do you always go for RP transplant, or do you measure the RP density in this post-operative?
No, I don't do the transplant. I just remove it, because what I see is that if I leave it like that, the whole complex itself is going to form a disciform scar. Even if you give TPAs, the blood clears off, but the central part scars off. So you're removing a much larger complex, and the actual photoreceptor damage area is smaller than the whole complex itself. So if you just remove it at one go, then only that central part remains damaged. But I have not been transplanting.
No, in that series of subretinal hemorrhages, if you see majority are not centered in the central fovea. Actually, though the blood is there, the membrane is not there.
Okay.
So that's where the RPE damage will not be the predominant. If it is centered around the center of the fovea, then the risk of having a large area of RPE atrophy.
Yeah, in such case that the 270-degree helps in transplanting the RPE.
In that case, probably the RPE transplant will help.
Another doubt is right from the beginning there is a chandelier actually. So we are talking a lot about the phototoxicity because in all your surgeries there is a chandelier always permanently placed in spite of using a light pipe.
No, I don't use chandelier for all, but I would actually like to. I mean, given a choice, I would put in all, but chandelier light doesn't cause phototoxicity actually. It's too far, and these lights are much better protected now than they used to be in the past. So actually a fiber optic for a long time would probably cause more phototoxicity than a chandelier lying away. Yeah.
For a very large submacular hemorrhage, I've been using the TAMR technique with the air, and the nice thing about that is it really displaces the blood very far away than you would otherwise get.
This is the
but the only problem is that you need to catch these patients early while the blood is still liquefied.
Yeah. So I was lucky. I mean, I didn't expect that kind of a result. I just put it, but I think here, as you said, the blood was fresh and it just displaced. But people who already have a thick membrane or something, there, I don't know how far it would work that effectively.
Sir, in the case you have injected the air, subretinal air, did you also inject TP in that case or just the air?
No, just air. Just air.
I'd also request the audience, if they have any questions, to please come up on the mics, and if you have any questions, you can please ask.
Yeah,
yes.
I have a question to Dr. AJ. What are the medical-legal aspects if you get a trauma cases like we guys sitting in periphery? We don't like to touch these cases, even though repairable very much in hands. But because of some issues related to their fights and quarrel, reported to police. So you may be summoned and that will kill your time, practice, everything. So how do you manage these cases in case you get in orders and all?
Probably Dr. Guruprasad, he has presented this thing.
So he's asking about the medical legal aspects of
No, let him answer first, the speaker. He is the speaker. Then we can
so
go
you
ahead.
Take the mic there, yes. The question is medical legal aspects of trauma. How would you go about?
Okay, if he could not get, then I need to.
So any trauma is a medical legal trauma. The first
any trauma is a medical legal, and we need to register. This is one essential step. If the patient is directly reporting to you, you need to make a FIR made and then proceed. Not taking care of trauma just because of fear of medical legal is more traumatic than taking care.
No, second thing is taking an X-ray orbit PA view, irrespective of whether it is blunt trauma or penetrating trauma, is mandatory. So because not taking an X-ray is going to be a medical legal issue later on. If they find any foreign body going in for any infection and the eye is lost, there is every chance that will be sued. So any case of this thing, imaging is important, especially the X-ray.
Yeah, I think Guruprasad now got the question.
I just want to add that counseling is the key. In any trauma case, apart from the police FIR and other things, counseling is the key. You have to do a detailed counseling about the pros and cons, about what the outcomes can be, about all the complications and the benefits. And recently, I think we have to start, at least wherever it is possible, you have to start audio recording and video recording of the counseling process, apart from documentation of the surgery itself in terms of recording. You have to record the surgery itself. This is what I have been practicing, and video recording and audio recording of the counseling process I want to start soon. So I think that will help in the long run.
Yeah.
Do you counsel about the number of surgeries also, sir? Because all this trauma will not be done with one surgery.
Yeah, we always tell them that they need multiple sessions, and it will usually be a week apart or a fortnight apart. And that is the way to explain to the patient about the gravity of the situation.
No, I have a question for you, because all your cases, you are very lucky, they are very clean actually. I think not even a single bacteria, not even you can find the common conjunctival flora in your cases. fortunately. But most of the cases which we see come with infection. So how the management changes if the patient comes with a foreign body with endophthalmitis, or maybe if they go in for infection later on.
We have had our own share of complications and lucks. I think patients who had apparently large foreign bodies have gone away, got away with no infection. And patients with very tiny foreign bodies which were successfully removed on the same day of surgery ended up with panophthalmitis on the next day, because the infection was lingering in the eye. So I think infection is something very unpredictable. We have to treat it prophylactically, and if endophthalmitis does happen, then we have to do resurgeries for the endophthalmitis itself.
So do you give a prophylactic antibiotic for all the trauma cases if it's open globe when you go for repair?
I usually don't, because it is very difficult to see the tip of the needle in most of the patients, and I don't want to inject into the suprachoroidal space or into the choroid itself. Unless I see the tip of the needle, I don't want to inject intravitreal antibiotic. I treat them with systemic antibiotics.
Thank you.
So with these
Dr. Hassan, I think, has been...
Yeah.
Sorry.
Dr. Hassan.
Let me just make a comment about what you were saying about counseling initially. With these difficult cases, I truly believe in under-promising and over-delivering. As you discussed with the patients, this probably paints bad prognosis or worse prognosis, but anything better than that, the patients are happier. So under-promise and over-deliver.
No, under-promising and over-delivering applies for all retinal surgeries, I think.
Your question, please. Yeah. So go ahead, please, your question.
Yes, still a comment on the trauma presentation. It's an excellent presentation, but in the eyes associated with traumatic retinal detachment, especially those with posterior incarceration, like the last case, in these cases, I think the prognosis is improved by doing chorioretinectomy and peeling the internal limiting membrane. Because if you leave the retina incarcerated into the posterior exit wound, it is an open track for reproliferation, which is a going on process. And also peeling the internal limiting membrane, reaching to the posterior exit wound will remove the scaffold for the proliferation. So I think these two procedures should be done in order to improve the long-term stability in these eyes and prevent proliferation.
So just to add to that, I'd like to ask the panel, we have seen a lot of cases where we have significant PVR, including anterior PVR. So do you have any experience with use of steroids or immunosuppressives like methotrexate in these patients? Do you have any experience, or anyone in the audience?
Can you come forward?
Yeah, I think Dr. Pulido has significant experience with that, so I'd like to hear from him.
So, I don't know, maybe 7 years ago, I described the use of methotrexate in these eyes. And the reason I chose methotrexate was because I had so much experience using it in patients with vitreoretinal lymphoma. And what I find with the use of methotrexate is that these eyes, so I give a dose of intraocular decadron and a dose of methotrexate. And the beautiful thing about the methotrexate is if you only give the decadron a day later, the eye looks good, but 2 days later, there's a lot of inflammation. But if you give the decadron and the methotrexate, then the eye looks quiet for about 2 weeks. And then Dean Elliott now and my colleagues Sophie Bakri and Ray Iezzi are using it weekly in these eyes with PVR, and they feel that it's very helpful to prevent PVR. Now it's all anecdotal though.
So do you inject it before you give the tamponade, let's say oil or gas, or do you do it at the end of the tamponade?
Yeah, so if there's oil, then I still just put in the 400 micrograms and 0.1 cc's with the oil inside of the eye. The eyes are very, very quiet. And as I said, initially it was just me doing it, but now there's multiple numbers of people doing it, including people in my own group.
Thank you.
Actually, Dr. Dean Elliott injects 13 injections of methotrexate postoperatively weekly, I think. Yeah, he calls every weekly and injects intravitreally every week.
Sir, there is a new concept of injecting mitomycin C. Actually, there are some papers under review as of now, in which eyes which are more prone for PVR later on when you, intraoperatively you find out. And I think Dr. Shukla sir also has some papers under review for that, where they are injecting mitomycin C to prevent, progression of future PVR.
I would be careful with mitomycin C within the eye because of its long-lasting effect. That one, we know from glaucoma.
Just the toxicity would be a major concern.
Toxicity will be high, but it is only, taken with a forceps. Although I don't have any personal experience, but people are using it. And they take with a forceps or a cannula, just surrounding the break to prevent further course of PVR.
I would be careful with that.
May I do it?
Yes.
We recently published an article in the Gravy Archives about the use of decorine in these penetrating trauma. And we inject decorine before doing the surgery, just after the occurrence of the trauma. And then doing vitrectomy, and the results are really marvelous. So I don't remember the dosage because it's a very complicated calculation, but we use it in about, I think, 30 cases, and the results are very good.
No, but what was the compound, sorry?
It's a decorine and...
Decalin.
Pardon?
Decalin, sir. High density.
Betadine?
Decalin.
No, not decalin. Decorine. This is an antimitotic, and it's an antimitotic, and it is the article is present in the Gravy Archives. I think this issue.
I think we should not confuse this to the audience because it's all controversial.
There's no strong publication on this. So I'd like to ask Dr. Stewart, you've very well described cases there where you have gone ahead with non-drainage, but if you were to drain, which technique do you use in scleral buckling? Do you go ahead with direct 26 gauge, or do you cut down? Which techniques would you advocate for drainage?
So for my drainage, I'll cut down with a 64 blade on the sclera, and when I get an exposed knuckle of choroid, use cautery. And I use the cautery on the surface just enough to get blanching of a vessel, do cautery to the exposed knuckle of choroid, and then I use a 30 gauge needle and come in relatively tangential, just far enough to get the bevel completely in, stay there for a moment, and slowly withdraw to try to decrease the risk of hemorrhage. So 30 gauge needle after cautery.
Great.
And I have one more question to Dr. Stewart. Sir, do you choose any cases for non-drainage, or is it like for inferior arteries, chronic arteries also you don't drain?
No, chronic arteries I'll not drain as well. My worry is inferiorly, because if I have a superior break and at the end of the procedure I've got fluid over the break, over the buccal, I may wait, but I always have the ability to put a gas bubble in afterwards. For an inferior break, if at the end of putting the buccal on I still have fluid, I'll probably change to a drainage procedure at that point, because I'm just not comfortable enough, especially in a chronic, thick subretinal fluid detachment, that it's going to settle. So superior, I'm willing to take more chances. Inferior, I'm not.
So those who are young bucklers, I think it's a very important point here that you must go ahead and read Dr. Shanmugam sir's article in Indian Journal of Ophthalmology. It's really good, gives you a very good overview of all the techniques, including finding the break, cryo, and also draining it. So we have a question here from...
No, but the issue with buckling with the young bucklers is first you have to learn the indirect ophthalmoscopy. No, because with all your wide field, nobody's literally going in for indirect. So without a proper indirect, so that's the reason why people have gone for chandelier, so that your life is made slightly easier.
So I'll just make a comment to Mike's paper. A lot of people don't realize that, a lot of us do realize, but I think it's important food for thought, that if you look at rates of myopia, right, patients who are best candidates for buckles are young, phakic, myopic patients who don't have a PVD. If you look around the world, by 2050, 50% of the world is going to be myopic. In Asia, it's about 90%. and patients who are -5 and more is going to go from 12% to 22%, right? So there's an opportunity that society should have, right? We can talk about buckles, a dying art, and all these things, but if we actually don't do something, it will die, right? Because all these people in the room are going to be gone, right, at some point, hopefully somewhere. Not for a while, Barry, not for a while. But I think if the society for next year, I think could be the first society that says we're going to actually have a problem that is a big issue in Asia, that says we're going to make this a priority and have a buccal symposium or wet labs or something, that I think that it needs to be done, right? We can talk about, every retina society, ASRs, we talk about all this, but we don't do anything about it, right? So I think going to Mike's point, if you just look at the numbers for myopia, they're just really, it's incredible, right? In China, 90%, and our world is here. It's not there anymore. It's here. So I would just suggest that as you look for next year, and you know, we're looking at this at the ASRS, Retina Society, but there has to be a way to try to fix the problem instead of just saying it's dying. So that's my comment.
Probably if we make the buckling material with platinum or gold, I think it might attract more industry.
Yes.
So
That,
actually looking at the macular buckle case that Dr. Manisha ma'am showed, done by Dr. Padmaja, that showed actually a very good anatomical sort of attachment of the macula, even in macular foveal cases. Does anyone else in the audience have experience with, or the panel, with macular buckling?
Yeah, I'm just regular buckles. So, you know, just let's concentrate on those first
that's
before we go to the
great point,
macula.
Yeah, let's talk about the regular buckling. There is actually a course at the Academy, AAO.
There is an
on
instruction
buckling.
course, which is...
However, my fellow went online looking for, videos of buckling, and there are very few. So if any of you have good buckling videos, you could put it up on YouTube for the rest of the world to see. I have a theory, hypothesis, that one of the reasons, among many, why buckling is dying is that many of the surgeons are becoming presbyopic and they're having a hard time looking at the scroll sutures. But we've been doing it under the microscope also, and that actually could overcome some of that problems and also be able to videotape some of these buckling procedures.
I think chandelier buckles are again a step in the right direction, because I think it makes an entire group of people who would otherwise be uncomfortable also get more familiar with buckling. So I think that's been a positive step forward.
Yeah, scleral buckle under a microscope is a good development. Actually, we were practicing for last 15 years, not now. Most of these steps are under microscope, and there is no need for any kind of a risk of not visualizing because of presbyopia or anything. But the art of scleral buckle is certainly, it is much more taxing. That's why probably people are looking for easy go, and more are going for vitrectomy, and whether it is required or not, putting silicone oil, which we need to resist.
I just feel with the chandelier, the traditional art of buckling, the indent and the dynamicity that you can get when you're depressing the brake and seeing with the indirect, I don't think the chandelier can match it. I don't know if anyone has any comment on that. Dr. Shroff, maybe.
No, it is good actually. If the brake is periphery.
Let Manish speak about it, because he's practicing chandelier for quite some time.
Yeah, that's exactly what I wanted to bring out, that there's no loss of dynamicity, because you're actually doing the same thing. You're indenting with your cryo or whatever, but you're seeing from inside through your wide field lenses. But the whole dynamicity is maintained. Actually, it's exactly the same, except you're not seeing with the indirect, and you actually get a much better zoom, magnified view, which you can control. So I would actually say that those of you who are very good buckling surgeons doing indirect, if you actually look through that, the view would be much better. But
and are there any breaks that you cannot use a chandelier, like the position of the brake where you don't feel that chandelier cannot be done?
No, actually it's the other way, I think.
There's no, because you can see all the minutest of breaks through this, the wide field viewing.
And also other areas of vitreoretinal tractions are better visualized under chandelier as compared to indirect.
No, I think Anirudh has a point. He's probably alluding, because if you have a break right where your chandelier is, you're probably going to get glare from there, and that might kind of
no,
create
you
a problem.
you can
seeing
change
it.
the chandelier.
Yeah,
with the
so
other
so you
ports.
can, yeah,
Yes.
you would probably have to
change.
be ready to change the
you
site of the
You
chandelier.
could just take
that
a
is the
switcher and change it to another. If that is a problem, it's not usual because you've already screened it beforehand.
Just pointing out that
Yeah,
little.
yeah.
No, from, Dr. Manish, Dr. Manish actually. There is no change in the pre-op, right? So we are going to localize the break pre-operatively, we are going to examine, so we are going to
Absolutely.
determine where you are going to. So it's not going to change.
No. Indirect has to be done for making sure what your pattern of the detachment, where is the break. I mean, then the rest of the surgery you can improvise inside, but your basic knowledge of the break is all there before.
No, the message should not be
Naresh,
like
what?
you can go and search for the break after putting the chandelier.
No. See, your
Naresh,
decision to do a buckle
the
is based on indirect.
preoperative meticulous
Yes.
indirect ophthalmoscopy is mandatory, and all the juniors need to practice this because we used to practice hours and hours, even to trace to the smallest vessel to the break, so that on the table, if you are missing something, then you can trace the vessels.
Yes, so that's the point we want to make actually. People should not think that go inside and then search for the breaks.
The
Not at
decision
all.
to buckle is based only once you've done a good indirect and established there is a single break or a whatever, whatever you're comfortable with. So indirect has to be pre-operatively.
Has to be done. There's a question there. Yes.
Can I have a question to all the panelists that in recurrent macular holes and large macular holes, how many of you are performing retinal transplantation? And what are the results? Like I have seen Naresh doing this, that when you take out a piece of retina and put it over the retina, over the macular hole, what is the functional improvement? Because you have the facility of doing a microperimetry and doing all those things. Is it really worth cutting a retina and putting it there and getting a functional improvement? Is the closing only endpoint of a macular hole surgery or getting some functional back?
I think he should answer because he has good experience, first-hand experience.
Well, I have conducted a few cases with full-thickness retinal transplant, and I can say that you can achieve anatomical closure. And in one of these cases, I did microperimetry after 6 months, and there was a central scotoma, but at the periphery, retinal sensitivity was regained. Probably this is the original retina of the patient. I do not believe that we do establish neural connections again between the transplant and the original retina, and this is something to be left to the future, I think.
Actually, whenever you are stuffing or using retina for closing the hole, what happens is the size of the hole shrinks.
Yes.
And the photoreceptor's whole layer comes to the center. That's where the appreciation becomes better. Not that the ILM stuffing or the inverse flap or the retina are going to act as improving the vision. Actually, it is the smalling, the hole becomes small, then the photoreceptor shifted towards center and appreciation becomes better.
The function is only at the original retina of the patient, not at the transplant. And this is something that has to be very clear. This is only mechanical closure of the hole.
Exactly.
Anirudh, I have a question for Dr. Hani. Sir, you advocated complete drying of retina in all cases of detachment.
Yes.
So in anterior break cases, do you use PFCL in every case?
Yes. I use PFC in almost all cases of detachment to drain the subretinal fluid through an anterior break. And for this, sometimes I do a fluid air exchange while keeping the PFC posteriorly and drain through the anterior break. And while still under air, I use the sandwich technique to continue PFC injection above the level of the break. This minimizes the amount of fluid that will trickle back to the posterior pole at the end.
Hani, you mentioned twice that when you did the fold correction, you did a fluid air exchange and then you put a PFCL and again did a fluid air exchange. What was the rationale for that?
Sometimes you cannot inject a single bubble under the retina posteriorly. You have to do multiple bulli in the posterior pole. In order to have these coalesce in the posterior pole, you do a fluid air exchange so that it pushes the whole fluid into one layer of fluid in the posterior pole that detaches the macular fold. If you leave them as separate bulli, you will not achieve the effect of ironing and flattening of the posterior pole.
Dr. Hani, actually there are two things. One is like, there are two presentations, one by us and one by Avnindra, I think, in Uretina. both of us, we peel the ILM. Actually, we use the same technique of injecting with 41 or 44 in multiple places detached. But why can't you peel the ILM also? Because that will relieve some amount of traction because after the fold is fixed for some time.
I have done this in one case and it helped to flatten the retina. Maybe I did not show it in my presentation. And sometimes peeling of the ILM and putting just fluid in the posterior pole and fluid gas exchange with proper positioning without PFCL, you can flatten this fold as well. Because the stiffness, especially in chronic folds, I mean folds that have been there for 2 or 3 weeks, peeling of the ILM can be very useful in helping to help the retina flatten back in the posterior.
And we come across this folds very commonly in GRTs actually. So the cases you have done is a giant retinal tear post-surgery, especially the cases with the GRT injected with the gas post-operatively have these folds actually. If it is not passing through fovea, we don't do anything. So the cases which you have shown are giant retinal tears or giant retinal tear?
No, there were no giant retinal breaks. I mean, giant retinal breaks you get usually the posterior slippage if you do a fluid air exchange and you have fluid still at the edge of the break. But if you do a direct PFC silicone oil exchange, usually, which is my technique, usually I don't get a posterior slippage.
Sir, and does your technique, like you are able to remove all the folds with PFCL alone, or do you have to make extra maneuvers in any of the cases?
Again, please, the question?
You have put the PFCL after inducing an RD in most of your cases.
Yes.
Like all the cases were successful with only PFCL, or do you have to do any extra maneuvers in any of the cases?
No, usually PFCL and draining the anterior fluid is quite enough. And as I showed you, I drain the anterior fluid with the 39 or 41 gauge needle using the silicone injection syringe, but on the extraction mode. So you can suck the fluid in the anterior retina and make sure that the posterior retina has been ironed and flattened completely.
No, here one question actually. You are injecting the fluid under the retina.
Yes.
So there are two options. You can either inject manually or you can fill the silicone oil injector with BSS and inject. So you use a manual injection or you use the injector mechanically to raise the blebs?
Yes. I use the mechanical injector using the silicone oil syringe. And I put some air above the level of the fluid so that this air acts actually as a to slow down the compression and the pressure inside the syringe and allow a gradual injection in the subretinal space. Otherwise, you would inject with a high pressure, and this may create a macular hole in some cases.
Yeah, more
so
than
putting just 1 cc of air above the level of fluid would allow you to just slowly compress this fluid inside the syringe.
So how to avoid RP? Because if you're not in the right plane,
how
to avoid the RP? Because if you're not in the right plane, instead of detachment.
Yes, this is a good question. I start the injection before I penetrate the retina, so that once I get into the subretinal space, immediately you get this bulla and you don't advance more. If you start penetrating the retina and then inject, you may get beneath the RPE. But if you start above the level of the retina and continue advancing, once you get in the right place, the retina will elevate and you stop advancing.
Great. So maybe you can take one last comment from anyone.
Well, one of the ways to avoid retinal folds, you mentioned giant retinal tears, but I've seen it with superior detachments, and there's still subretinal fluid, and the patient doesn't face down, and then that fluid actually can end up with a macular fold. So I think post-operative positioning in those cases could prevent having macular folds.
Yes, we can argue about the post-operative positioning. I have tried the face-down positioning and found that still in some cases I get the folds because simply the buoyancy and the flotation force of the gas may make the posterior retina attach prematurely while still there is fluid and it is stretched. What I usually do now is I leave the patient supine for the first 6 hours and I leave some fluid above the level of the macula. I do not do a complete fluid air exchange and leave the gas bubble. After 6 hours, when the posterior retina has reattached from posterior to anterior, I let the patient on the face prone down position.
Thank you. So thank you very much to all the experts. We've had a great first session where we have seen excellent vitreoretinal surgeries and also learned the importance of scleral buckling. So we can break for coffee. We have the next session in this hall at 11, and I encourage all the audience to go for the poster viewing. The coffee is at the back of the hall. Thank you.